and taxane, carboplatin in combination with paclitaxel. This is the chemotherapy backbone. And irrespective of MMR status or microsatellite instability status, now recommendation is to add immune checkpoint inhibitors to those patients who have measurable disease. So biomarker testing is a must in endometrial cancer. As I was discussing, we do in all patients of endometrial cancer nowadays. Around 25 to 26% of 25 to 30% of patients of all stages of endometrial cancer do have deficient MMR or microsatellite instability. So there you are having higher chances of response with immune checkpoint inhibitors, and we are discussing of potential cure in such patients with immunotherapies. So in our clinical practice, we do use promise strategy whenever we have to do molecular profiling for endometrial cancers. First of all, we test for pole mutation. If pole is mutated or ultra mutated, then you are probably dealing with a good cancer. And prognostically, these patients do very well, even in absence of any sort of adjuvant treatment. So pole mutation is a good prognostic factor in endometrial cancer. If pole is not mutated, then we test for MSI. We call it microsatellite instability, or you can test for deficient MMR. So this is the second step. Third is, if both are negative, then you have to test for TP53 mutation. And TP53 mutation is again associated with poor prognosis. So even if you are dealing with relatively less aggressive histology like endometrioid, but if TP53 is mutated, then probably you are dealing with a bad cancer. So TP53 negatively impacts the survival of patients having endometrial cancer. If all of these three are negative, like pole is not mutated, MMR is proficient, microsatellite is stable, and TP53 is not mutated, then we call it NSMP. So these are four molecular varieties of endometrial cancer, and irrespective of histology, we test for these markers. So Ruby trial was a phase 3 randomized trial. There are two parts of this trial. We will discuss the data of part 1 today. And part 2 included patients who were put on the dostarlimab maintenance plus PARP inhibitors. And the data is strongly in favor of, particularly in patients who are having proficient MMR status. So we will discuss the data of part 1 trial. We have, long-term follow-up data of this trial. I think it was around 55.6 months. And this data is was presented in ESCO 2026. So we have updated survival data, overall survival as well as progression-free survival data of this trial. So in this study, patients having advanced endometrial cancer like stage 3 and stage 4 or recurrent disease, but they should have measurable disease. Means if patient is having stage 3 and underwent complete cytoreduction and they did not have any measurable disease, they were excluded from this study. So patients should have a measurable disease, and they were randomized into 1:1 fashion to either dostarlimab in combination with chemotherapy, paclitaxel with carboplatin, and control arm had placebo plus chemotherapy. And this was given for 6 cycles, and then in experimental therapy, Jemperli was continued at a dose of 1000 mg every 6 weekly for 3 years. Primary endpoint being overall survival for all comers and progression-free survival for all comers. And there was subset analysis as per deficient MMR or microsatellite instability score. So we will discuss the data as per this subgroup analysis. So if you talk about the proportion of patients who had deficient MMR status, then the number was 118 out of 494. So roughly nearly 25 to 30% of patients had deficient MMR status. So as I was discussing, these patients should have measurable disease, and patients who had recurrent endometrial cancer but they received chemotherapy more than 6 months back, they were allowed to participate in this study. So one good thing about this trial is this included patients with diverse, disease characteristics. Majority of patients, nearly 55% of patients had endometrioid histology. 20% of patients had high-grade histologies in the form of serous carcinoma. 10% of patients had carcinosarcoma. So basically, all histology were in this study. And if you talk about age of patients, then 48% of patients had age of 65 or more. If you talk about the biomarker status, then deficient MMR or microsatellite instability was present in 24% of patients. So if you see the overall survival data in all comers, irrespective of MMR status, then there was median improvement of nearly 16 months in this study. So now we have follow-up data of 55.6 months. You can say even 4-year survival data. So after 4 years of follow-up, nearly 73% of patients were surviving in combination arm, that is dostarlimab with paclitaxel and carboplatin. So there is a huge and significant improvement in overall survival with addition of dostarlimab even in all comer patients. Now, if you see the another major primary endpoint, improvement in progression-free survival. So if you see the median progression-free survival is 11.8 months in dostarlimab plus chemotherapy versus 7.9 months in only chemotherapy, which is clinically meaningful and statistically significant. I think this is a bit old slide. Now we have 4-year follow-up data. So after 4 years, the progression-free survival, proportion of patients having progression-free survival is 58%, 57.9% to be precise. Means out of 100 patients, if you give dostarlimab plus chemotherapy, 58 patients will be having progression-free survival after follow-up of 4 years. That is, wonderful data. Metastatic endometrial cancer or recurrent endometrial cancer, if you treat 100 patients with dostarlimab plus chemotherapy, 58 is going to have progression-free survival after 4 years. So there is one another stat I was going through. After 12 months of follow-up, if patient is having progression-free survival, then there is 88% probability that these patients are going to have progression-free survival for 4 years. So this is something which is very significant, particularly in patients who have deficient MMR or microsatellite instability score of high. Now, once you establish that we are improving the survival and patients who are very symptomatic, there you tend to look for overall responses, how fast you are getting the response. We know that those patients who respond to immunotherapy, they are having durable responses, so they can continue to respond for a long period of time. If you see the objective response rate and duration of response after 2 years of follow-up, then nearly 70% of patients had some sort of response, all comers, irrespective of MSI status. 45% of patients had partial response and 25% of patients had complete response. With chemotherapy, the proportion of patients who were responding is a bit low. It is nearly 65%. So addition of immunotherapy, dostarlimab, does improve the overall response rate as well. Now, if you see the subgroup analysis as per deficient MMR status or microsatellite instability high, then median PFS was not reached versus 7.7 months in only chemotherapy arm. So you can see the survival curves are getting separated very early, and this is the classical immunotherapy survival curve. These patients do well. After a particular time, the curves become plateau survival curve and they continue to respond well. So these curves are getting separated, tail of the curve is getting separated for a relatively long period of time. again, coming to the overall response rate, which is significantly higher in those patients who had deficient MMR status as compared to patients who had proficient MMR. Addition of Jemperli to chemotherapy improved complete responses, complete remission rates, and durability of response was higher with addition of immunotherapy. Now, if you see the median overall survival difference in patients who had proficient MMR, so although the benefit was there, but it is not that marked as compared to patients who had deficient MMR. So obviously, those patients who had deficient MMR, they were benefited more as compared to patients who had proficient MMR status. This is the classical dosing of dostarlimab, Jemperli. Initially, we give 500 mg 3 weekly for 6 cycles in combination with chemotherapy, and then we have a maintenance phase of 1000 mg every 6 weekly for 3 years. So I think we have already discussed all these things. This slide is a bit old slide. We have follow-up data of 55 months of this trial. And overall survival after 4 years is proportion of patients having who are surviving after 4 years is 73% as compared to 14% in 40% in only chemotherapy. Proportion of patients who had progression-free survival is nearly 58% in dostarlimab plus chemotherapy after 48 months as compared to only 14% in chemotherapy. So irrespective of biomarker status, irrespective of TP53 mutation, all the patients were benefited with addition of dostarlimab to chemotherapy in all histologies of endometrial cancer. Now, what about the patients who progressed after chemotherapy? So majority of these patients did receive immunotherapy as second line treatment. So you can safely say that addition of immunotherapy does give survival advantage to patients who are having endometrial cancer. Now again, with immunotherapy, typically we discuss the data PFS2. PFS2 means patient has progression after first line of treatment, and then subsequently patient received some sort of second line treatment. And what about the progression-free survival with second line treatment? So one good thing about these immune checkpoint inhibitors, that even after progression on first line, they continue to receive some sort of benefit with immunotherapy which was given earlier. So that's why this concept is coming more and more in oncology, particularly with these drugs immunotherapy. So we discuss about PFS2 data, and PFS2 was significantly higher in deficient MMR population of patients who received dostarlimab in combination with chemotherapy. Even in those patients who had proficient MMR, benefit was there, but it was not that significant as compared to deficient MMR status. Now coming to treatment-related toxicities, once you establish that this drug is effective, you have to look for long-term toxicities, and treatment-related discontinuation rates were 19% in dostarlimab plus chemotherapy arm. Few toxicities were higher in combination arm. Obviously, immune-mediated toxicities we experience in the form of endocrinopathy.
Dr. Chandrasekhar, summarize.
Just one more minute. Elevation of liver enzymes. So these are the common toxicity we experience with immune checkpoint inhibitors. So we have discussed the dosing guidelines. So to summarize, in patients who have primary advance, that is stage 3 and stage 4 endometrial cancer, or if patient have recurrent endometrial cancer, but they should have measurable disease, addition of dostarlimab to chemotherapy backbone, that is paclitaxel and carboplatin, does improve survival. You have a median improvement in overall survival of 16 months in all comers, irrespective of MMR status. We have got strong progression-free survival data. Toxicity profile is manageable. Treatment-related discontinuation rates is almost similar between both dostarlimab plus chemotherapy and only chemotherapy arm. So this is the new standard of care in patients who have stage 3, stage 4 or recurrent endometrial cancer who have measurable disease. So with this, I would like to stop and thank you all for patient hearing.
Thank you, Dr. Chandrasekhar, for excellent presentation. Take-home message of his presentation is dostarlimab plus paclitaxel and carboplatin chemotherapy followed by dostarlimab maintenance improves overall survival as well as PFS. Yes. Of course, MMRD subset drives much benefit. Any opinion, suggestion, and questions from the floor? If one or two. Okay. I think due to shortage of time, we will proceed for the next presentation. Dr. Priya is there? No. We will proceed to panel discussion in DLBCL.
Yeah. So, with your permission. Hello. Hello. Yeah. So, with the permission now, we are moving to a panel discussion. This is management of DLBCL. And to do the honors, may I request Dr. Ashik Ape sir to please come forward and introduce the panelists.
At the outset, I would like to thank the organizers for providing me this opportunity. Bit change. I think we have one of the stalwart. I will request Dr. Atul Sharma sir to come on the dais to provide his expertise. He doesn't require any introduction, definitely. Sir is a very senior medical oncologist, chairman medical oncology in Max Hospital in Delhi. The other panelists, I will request Dr. Tejaswini Vaid. Dr. Tejaswini, she is a consultant in medical oncology in Medanta, Gurgaon. Dr. Priyanka Aswa, hematologist from Ranchi. And Dr. Dipti Rani Samanta. So, professor and head medical oncology, Acharya Harihar Postgraduate Institute Cancer, Cuttack. Dr. Dipti Rani is there? My bad. Sorry, ma'am. Yeah, so anyway, this is a huge topic. I mean, sir will agree. 25 minutes and management of DLBCL is definitely not possible. DLBCL itself requires an entire conference, actually. So I think there are certain, things. I mean, sir will agree. DLBCL is not a one disease. So we should know subtypes, but how much that changes management, it's really questionable sometimes, or we prognostic risk stratification, well, let's say early stage interim PET, late stage, whether we are gone away straight for R-CHOP or still it remains a backbone and, we just keep changing. Role of CNS prophylaxis and maybe if we have a time, then, the additional. So I'll ask, first, I think it's sir. So what do you think, like how important is there, when you're looking at IHCs or, we say GCB type, non-GCP or ABC type, or do you do molecular assessment now? Because, now there are certain labs, they are providing even the molecular NGS now with the lymphoma. So do you routinely send or, yes, sir?
All right, so I think it goes without saying that the cell of origin is must. Yes. We need to know GCB, non-GCB, or you want to call it GCB versus ABC or this thing, that is definitely. And what we have this thing, simple classification based on 4 or 5 molecular marker, immunohistochemical marker, you can come to that. So in most of the center, if I'm not aware that whether we are trying to find the cell of, or we do the NGS at the baseline or this thing, but I am aware that more and more guidelines are coming with the fact that we should be knowing that molecular cell of origin or basically NGS what we are doing for many other disorders should be done. But minimum is the Heng classification. You need to know whether GCB or ABC.
Dr. Samantha, madam, do you do routinely NGS?
No, routinely in our center we are not going for NGS, but as Dr. Atul pointed out, we adopt Hans algorithm to taking all the markers in ISC. If you are seeing it is CD10, then positive, then you are taking it GCB, then you are proceeding to BCL6 and MOM1, etc. to stop the disease as GCB or non-GCB. But it's the most important thing nowadays for the clinical practice.
Dr. Tejaswini, you do IHC-based classification and do FISH for everybody, or how you do it?
We do IHC-based classification as well as FISH for everyone.
Yeah.
And that's largely because both from a prognostication standpoint, that's important to know whether it's GCB or non-GCB, as well as some therapeutic decision making can depend on that. So we do both of these.
So Dr. Priyanka, like we have this, we have IHCs, we have everything. Yeah. But what is usually your go-to regimen?
Definitely, this is very important, as Dr. Tejaswini also told, to decide the regimen. If it is a double hit or a triple hit lymphoma, so our regimen will change accordingly. So we are generally going through higher regimens like RDA epochs like that for double hit lymphomas, and ABC and GCB also we are changing our regimens. Usually POLA, RCHP like that for the ABC subtype. So definitely the classification is must.
So sir wanted to say something.
So I'm not sure whether fish is indicated for all the comers or this thing. Personally, I suggest if there is indication based on ISC, BCL26 and this thing, that CMYC, then if they are double expressor, then of course it should be confirmed by the fish.
Yeah.
But I'm not sure whether we should be ordering fish for everyone. So
I am
So
doing that. Sir.
I think so. Most of the guidelines are saying if you are IC, I mean MIC is positive, then definitely you should look at the fish because you know you can miss out BCL2 and other things and you will miss out. Because only CMYC positivity may not actually indicate a poorer prognosis in the
If MYC is positive, you have to go for fish to see the gene rearrangement in BCL2, BCL6 also.
Also in the newer pathology classification, if someone has a CMYC positivity on fish, even if the histology, histopathology is suggestive of a DLBCL, we reclassify it as a Burkitt-like lymphoma, and the treatment will change. So in such situations, we definitely cover the patient and do a
but
fish.
see, the Burkitt, like more of you will go by Ki67 somehow, you know. Now, Burkitt lymphoma, you know, because we always used to have this differentiation. Now they are saying Ki67 100%. Then only probably you will say it's a Burkitt's.
But the CMYC positivity on fish, we have to reclassify it as Burkitt-like.
So this is what we are looking at. You know, if you have a CMYC on the IHC protein expression more than 40% probably, then you will look at fish. And you know, only if it is a IHC positive, you will say double expressor. If it is a fish is positive, these are double hit lymphomas. And then definitely you are looking at these novel agents. So this is something again, you know, I just wanted to classify GCB, ABC, and if you are doing NGS, so then I think you will refer to this lymphogene classification. But I mean, I will ask sir, actually, you know, even after doing this classification, does this impact your treatment decision or probably it's prognostication, more or less?
I think this is more of the prognostic significance.
Yeah. So, so are you keeping this data for all these patients?
No.
Okay. Madam, are you having any clinical trial or anything you are looking at?
No, it is only for prognosis because we do not change our therapy according to that.
Yeah. So if you look at NCCN, you know, these
but I buy your this thing assessment that we should be keeping a data of this. Yeah.
So this is, you know, when I was looking at DLBCL, these many subtypes are already there of DLBL. So I think what we are looking at is not a single disease, and you know, you have these various, I mean, like depending on what actually features are there, you can do the IC panels and things. So next I will come to, you know, risk stratification, which is the commonest score which you use, Dr. Tejaswini?
We use the IPI and the CNS IPI.
Okay. So basically, these are the various, you know, modifications of IPI we look at. You know, first IPI, which was, you know, you have 5 points age more than 60, LDH, the PS24, stage 3, 4, and external. Then came age-adjusted IPI. I think you look at the NCCN guideline, then probably you have to look at stage modified because, you know, early stage DLBL is something which is very different. And so this is something like DLBCL journey, you know, screening, diagnosis, you will have first line treatment, probably you will end up curing almost 50-60% of the patient, but 30 to 45% will be relapse refractory. Second line will either go for CAR-T and, you know, disease relapse. So these slides I borrowed from my colleague, you know, Dr. Lingraj, and this is what his data, 300 odd DLBCL, 200 will be cured, 100 you will have relapse refractory, out of which 50 will be almost transplant ineligible, 50 will be transplant eligible. Out of all these 50 transplant eligible, probably will end up curing some 10 patients. So what we are looking at, this almost 90 patients which are there, which is almost in that, you know, I will say 30% of the patients. This is something which is an unmet need in DLBL. So treatment landscape again in DLBL, I think R-CHOP or actually CHOP was the standard of care, then came rituximab, you know, in 1997, now to rituximab, almost everyone can afford. I don't think we can imagine any CD20 positive lymphoma not being treated with. Other CD20 antibodies did come, you know, obinutuzumab was there, other things, but I think barring follicular lymphoma, I have not used obinutuzumab in this. And latest addition in 2022 was, you know, after POLARIX trial was a POLA RCHP. So early stage DLBCL, sir. So do you use ISRT, you know, as per these guidelines, sir, you know, you classify and you use, or you rely upon completely on the chemotherapy, sir?
I think systemic treatment probably is able to take care of most of these.
Yeah, so, but sir, I mean, like these guidelines, there's a PET-based guidelines which are there, now interim PET, and, if you have doable 1 or 2, probably just give 1 R-CHOP, and, if it is a high risk, just give ISRT. So how many of us are actually following ISRT?
So at least I don't follow this.
Even I. So that's the reason I asked you. Anybody, Tejaswini?
I do. If it's a bulky disease, if the patient achieves a CMR on PET.
Bulky disease, I completely agree. I am saying a routine DLBL, stage 2.
Only.
Stage 2, non-high risk DLBL, will you do like PET guided, 3 cycles, do PET scan, then do ISRT?
No, not in that case.
Yeah. But that is the thing is that is what the guidelines basically recommend. You have you have low IPI, PS was non-bulky disease. Probably you will just give 1 cycle or IFRT. I think most of us are completely relying on the systemic therapy. The IFRT probably we will give is a bulky mass or maybe residual disease.
So let me ask maybe that fellow panelist. So do we for the early stage we follow 4 cycles or we go up to the 6 cycle as per the guidelines?
I go give 6 only, sir.
Anybody who is
4 cycles.
But do we have good data about the 4 cycle? Early stage?
So interim PET data is one of the most worst, I will tell you. See, my thesis was interim PET scan. So I will tell you when actually I looked at interim PET scan in DLBCL, like Hodgkin's you have, 2 cycles PET scan. In DLBCL you look at the trials, it is from cycle 2, 3, 4. You have all and none of them. I'll even come to that. So that's the reason I'm saying. So really, at what is point of your interim PET scan? 2 cycles, 3 cycles, 4 cycles, because this says 3 cycles.
Interim PET, we cannot change the line of therapy actually. That is only to know the result, chemoradiation, nothing else.
See, ma'am, if you, the thing is that probably if you're looking at progressive disease, other things, maybe, clinically, then I think you need to change up or even with the partial responses. Yeah. So there are certain studies which are, there is a escalation and de-escalation. I'll come to that. Either, there are studies where you, after 2 cycles, you get a PET scan done. If it's a doable 1, 2, or you see response which is more than 65%, you will continue with that. Otherwise, those who had less than 65% response, you classify them to R-CHOP 14 versus a Burkitt-like regimen. And probably, but what increased was a PFS only, it was never with
so
OS.
Personally, I probably would go up to 6 cycles. I do understand, even we do, I think, the interim PET, but that is mainly for knowing the disease biology rather than the changing the treatment.
Yeah.
If you are not doing interim PET here, there is no disadvantage because after anyhow you have to go for 6 cycles. After 6 cycles, you can have 1 PET scan. Before that, 1. Early stage is okay.
I'm not sure whether there are studies which have kept the chemotherapy at 4 cycles in the early stage.
See, I think the probability. No, so I think the interim PET scan is your basically measure of chemotherapy reduction, whether it has reduced lymphoma or not. That's the most thing which you wanted to know. And probably, what is going to be the pathway for this patient. And this trial I was speaking, which is a petal trial, here they have given this R-CHOP 14, 2 cycles, and interim PET was done. So if the PET scan has become, negative, then they will go ahead with, R-CHOP along with this, or if they are positive, then they have classified. But what they have seen, there is even with the IPET to high-risk patient, there is no significant difference in the time to failure OS across both the chemotherapy arms. So probably even when you are doing this, you just know this is the patient, I have to counsel them, probably you are going to require transplant or maybe you are a CAR-T kind of patient.
But sir, here, if the interim PET has like a CMR already, in that case, even this mentions to give only 4 cycles of R-CHOP.
Plus 4. 2
That's
plus
right,
4.
2.
So 2 prior and
2 prior and 4
Okay.
later. Yeah.
I take it that way.
Yeah. So I think this is algorithm for PET. I mean, this is NCCN guideline stage of the disease. You have 1, 2, bulky IPET after 3 cycles. If CR, they are saying 1 cycle of R-CHOP, but I don't follow this. I say this is, this is, if you have responded, you are curable disease. I complete with the 6 cycles. If the partial response is there, maybe again after 4 cycles, I repeat whether, there is a progression or not. If there is a progression of the disease, then definitely. And those with the 2 or bulky disease, probably we do, complete 6 cycles and you try to look at it. And if you have a bulky disease, this is something, again, for guidelines for, DLBL early stage. But I think most of us, I don't practice ISRT as of now. I give IRT only to the bulky disease if at the baseline. And the thing is that if there is a residual disease post-treatment. No, advanced stage DLBL, sir. What is your take on this? So how do you really classify, like this is R-CHOP, R-dose-adjusted epoch, and how many times really can you deliver dose-adjusted epoch or polar R-CHOP? RCHP, sorry.
So high IPI 345 and advanced stage, patient eligible for I think this thing, so I prefer to give polar RCHP. And dose adjusted, usually I select in very few patients. Not that it's not deliverable, but I think there are set indication, either PMBCL, that is one, and there are one or two others, HIV associated thing. And but generally for the, I do understand that probably maybe someone will say, for the double expressor, double hit or triple hit, we should be more aggressive, but I don't know whether that really is making a difference. So that is my practical take. 2 or 3 indication, polar RCHP, definitely eligible patient, dose adjusted PMBCL or 1 or 2 high grade or this thing once in a while, but by and large this is our job.
Samantha, madam?
Polar RCB not mandatory for every lymphoma, because I think besides what Dr. Atul pointed out, and ABC subtype is also an indication for this polar CHP. It is not cost effective and should be reserved for these high risk patients as well as cell of origin ABC subtype.
Dr. Priyanka, what is your take on? I mean,
Yeah, exactly what madam told is ABC subtype and elderly patients, polar RCHP will be, those patients will be benefited. For double hit and all, I definitely go with RDA epoch if the patient is young and fit.
Okay. Dr. Tejaswini?
So I prefer polar R-CHOP if the IPI is high, polar RCHP if the IPI is high, and if it's an ABC subtype. As far as double hit and or double expressor is concerned, when we look at the DLBCL, there isn't a lot of concrete evidence that escalating therapy does better, actually. Unfortunately, we don't have a very clear answer to that. It's different from in high-grade lymphomas. In high-grade lymphoma, yes, escalating to DIPOC-R is recommended.
Yeah, so if you look at the various trials, even I think polar data, if you look at probably ABCTI is subtype high IPA, but the typical DLBCL, which is like PMBCL, which is there, your Burkitt-like lymphoma, I really don't think so adding polar makes any sense. Yeah. Second thing is that even if you look at the data of dose-adjusted epoch versus the, even R-CHOP, it's PFS what you get at, and probably with high IPI, in the lower IPI, even if you have high-risk features, I think there is not much difference whether you give dose-adjusted epoch versus R-CHOP. Sir,
I just want a clarification, maybe because you also treat and maybe fellow panelists or this thing. Where Polarix trial design probably did have 2 maintenance rituximab.
Yes.
So everyone practice that?
No, sir. That's why I'm going to come there also. So, R-CHOP as a treatment regimen. So we have, low IPI, early stage disease, GCB phenotype, you have good. But you have high IPI, age more than 60, non-GCB, you have double expressor, you have CMX, then you are looking at the low curability. So people have done all these things, with the R-CHOP. They have put escalated rituximab, they have they have, ABC type people tried bortezomib, or you have R-CHOP, or bevacizumab was added, or any novel agent. I think probably what you got was more response rates, but it never cured the DLBL, because that is something which we are looking at. So, this is what basically, shall we look at cell of origin, so all these things, so ABC and GCB type. So people tried with ibrutinib, again, if you look at even there is a data for elderly patients who are not chemotherapy sensitive. This is a Canadian protocol where you can just use rituximab, ibrutinib, lenalidomide. This is one of the fantastic protocol which I have also used. But I think adding these agents, like in the solid tumors, you have mutation, you give targeted, that is not we are seeing, I think probably. And this is, several studies, they try to optimize R-CHOP in the various manners, but they failed. You add various agents, but I think you are treating once it's a relapse refractory, probably anyway, only chemotherapy is not going to cure it. Any panelists wanted to have a take on this? Dr. Tejaswini?
Agreed with this, that there might be some EFS benefit like with lenalidomide and some other agents, but there's no OS benefit proven with any of the additions.
So I think the only thing which has, was this one trial, which was R-CHOP with R-ACVVP, where it has improved, but with almost almost 60-70% of the patients having grade 3-4 toxicity. So this is which was not practical. And this R-CHOP or this botulinum R-CHOP, which was there in ABC type. This was something which is there, and not to mention Polaris. So I think R-CHOP with R-Polar-CHOP, we have already discussed with this, and what sir was saying is also very important thing. But I think I'll come to the, so this is a 5-year analysis of R-Polaris, and we can look at the Polar CHP, almost PFS is 64.9% versus R-CHOP is 59.1% with hazard ratio 0.77. And this is, what we are speaking about. You look at almost, all subgroups, but you will not see, it is almost, many of them have actually cross unity when you are looking at all these subtypes. It is not that, but subgroups which with the greatest benefits were IPI more than 2, ABC subtype, double expressor status, absence of bulky, and probably older patients more than 60. So central nervous system prophylaxis, sir, where do you give it, and what is your go-to drug? Do you believe intrathecal or high-dose methotrexate?
So we used to, and let me say, I used to,
Yes.
but nowadays there are more and more data coming that prophylactic ITMTX probably may not be useful.
And high-dose MTX, you put the intermediate, or you finish all R-CHOP or whatever and you give?
In between probably with this thing, R-CHOP.
Samantha, madam?
Actually, what nowadays we are feeling that ITMTX or IT-cytarabine is not helping us much. The concept of high-dose methotrexate, when you are considering, it should be given before day 10, because otherwise whole protocol will be disturbed and toxicity, everything will happen by which patient cannot receive the whole protocol. The data is not that much very extensive, and we have to wait for the data. High-dose methotrexate, till now we are giving intrathecal, but now we are thinking that it's not helping, and the concept of high-dose methotrexate is coming nowadays.
Dr. Tejaswini?
The guidelines themselves mention that the benefit is unclear, and as ma'am mentioned, that adding a high dose methotrexate in between, not everyone is able to tolerate it. So the best strategy we still don't know.
So I think everyone will look at CNS IP, and even sir, I think most of us have used intrathecal methotrexate, but now we are giving to, and actually if you look at even high dose methotrexate, this is the only trial which was positive and that showed benefit hardly, but not other trials. But I think most of the times, I think madam also pointed out, people have tried it, when they put actually high dose methotrexate in between, probably there were delays in the cycles of the R-CHOP. So now they say complete all 6 cycles.
We give at the end of
just give
therapy.
2 cycles, which is 3 to 3.5 gram per meter square of high dose methotrexate. Because of the lack of time, I will just come to the last only part, just give me 2 minutes. Sir, like now in present era, which are your patient at relapse or whatever, you will go for CAR-T versus autologous transplant. Autologous transplant has stood a test of time, and we will always debate auto versus CAR-T. But which is the subset where you will take a call, okay, this is for CAR-T, this is for autologous transplant?
For my practical take, the clear cut will be the somebody who relapse within 1 year, probably I'll definitely suggest CAR-T. Yes. Beyond that, you can discuss CAR-T versus auto. But within a year relapse, I think I strongly suggest or recommend that CAR-T should be the option.
Same thing. Actually, early relapse, CAR-T will help. Less than 12 months. After that, you have to concept of autologous stem cell transplant is coming, and within 1 year, CAR-T helps.
Okay.
But in most scenarios, all patients they can't go with CAR-T, so that time we go with salvage chemotherapy and for transplant. But results will be much better with CAR-T.
That is a conception. You can go for aggressive chemotherapy.
I think fundamentally, a disease that is primary refractory or relapses within a year is not chemosensitive.
Yeah.
So these patients are less likely to benefit from a transplant, which is why CAR-T is probably the best option for them.
Yeah. So I think most of us, agreed. What is the timing of relapse probable post-treatment? Less than 1 year. And even if you look at whether there was a previous rituximab exposure or not, but I think that data was pre-rituximab. Now almost everyone gets rituximab, so we really can't depend on. And that is something what we are looking at. You have relapse refractory, less than 1 year, probably you are going for their CAR-T cell. If not, then probably you have to do some sort of clinical trials or something like that. If more than a year, if they are not, for autologous transplant, sometimes you have 65, 70-year-old patients, you may not be able to. Then you have various, second-line agents. You have glofitamab, you have tafasitamab. So all these agents we can try, and depending on, ABC subtype is there, you can give lenalidomide, you can give ibrutinib. So all these things which are there. So, but what we are looking at, this almost 30 to 35% of the patients which are there of DLBSL, I think we have to really work hard, and I think there may not be a single strategy which is going to be useful. So these are some approved CAR T cells, and I think most of us, so any one of you doing CAR T? So, sir, what is your experience of CAR T? Now you have Indian CAR T, definitely I have not mentioned here Indian CAR T, which is there through ImmunoAct, but what is your experience on Indian CAR T?
Very limited. Reyes has more experience, but obviously the different CAR T data is different. So
Yeah. Madam, you are Tejaswini?
I think one thing which is in favor is the low degree of toxicity. We've had just a couple of CRS. We've not had any neurological toxicities. The cons, of course, are we don't have enough data. I mean, of course, any institute's numbers will be small. When we look at the published data, I think we need more data to understand what are the CR rates in the long term.
So, sir,
Yes.
any long-term patients on Indian
We
CAR
do.
T?
We have patients
So
who've
how,
crossed.
I mean, like, just give a ballpark figure. How many like you have treated with Indian CAR T? I mean,
Right. We've only treated with Indian CAR T. All our patients, we have a few who've been treated with the ImmunoAct product. We have a few who we've treated with the
longest
Immuno.
survival, or you say your, I mean, response rates are in the tune of 60.
I
when you look
think
at
we
the data.
have a few patients who've definitely crossed the 6 months mark, but that's still early. The earliest we did who've crossed 1 year, one of them has definitely relapsed. The other, I will have to see what the follow-up is.
Sir,
from the data I'm aware of from the AIMS Medical Oncology Group, probably about 40
45%. Yeah. So I think thank you very much. I think it's a vast topic, but thank you all panelists, and special thanks to Dr. Atul Sharma sir, pitching in the last time for giving his expertise. Thank you very much.
So thank you, Dr. Ashay, and the esteemed panelists for a wonderful panel discussion. May I request Dr. Deepirani ma'am to introduce the next speaker?
Again, now welcome all of you to the gynecological oncology session. Second speaker has not finished. And second speaker is Dr. Priya Nayak, Senior Consultant and Medical Oncologist, SOM Ultimate Medicare, Bhubaneswar. She is going to present PARP inhibitor in advanced ovarian cancer beyond BRCA and HRD status. Dr. Priya, please.
Good morning, everyone. So, and thank you everyone for joining us today. So, today we'll be discussing regarding PARP inhibitors in advanced ovarian cancer beyond BRCA and HRD status. So, over last decade, we have witnessed a remarkable transformation in management of advanced ovarian cancer. So, traditionally, we used to focus only on achieving a best response after cytoreductive surgery and followed by platinum-based chemotherapy. But now our focus is shifting into also consolidating the response that we have achieved by starting some good concrete first-line therapy. So now in this era we have this PARP inhibitors, which is very highly effective in platinum-sensitive patients. So today's focus will be on niraparib and some pivotal clinical trials and some real-world database trials also. So this is a GSK sponsored topic. So now let's go to ovarian cancer and treatment journey. So if you see first-line PARP inhibitor maintenance therapy has shifted the ovarian treatment paradigm. So like initially, like I was saying, our focus was only on debulking cytoreductive surgery followed by chemotherapy. But now with introduction of PARP inhibitors, we have achieved a very durable response after our adjuvant therapy. So like despite advances in surgery and chemotherapy and biomarkers, 70% of patients with advanced ovarian cancer will relapse in first 3 years in absence of first-line maintenance therapy. So now the goal of maintenance therapy is to prolong benefit following surgery and chemotherapy, induce a lasting remission or improve disease-free interval, in terms of PFS, PFS2, OS, and manageable toxicity and minimal negative effects on quality of life. So now this is a data landscape in evaluation of first-line therapies that have enhanced the standard of care for patients with advanced ovarian cancer. Like in 2003, through GOG 178 trial, paclitaxel came as a first-line maintenance therapy. Then followed by bevacizumab was first-line maintenance therapy in 2011. Now SOLO 1 trial where BRCA mutated patients were given olaparib was first-line maintenance therapy. It was introduced in 2018. Through POALA 1 and PRIMA, we have olaparib plus bevacizumab was first-line maintenance therapy and niraparib respectively. Now again, Athena mono came, which introduced rucaparib as the first-line maintenance therapy, and again there is PRIME trial, which again reinforced niraparib as first-line maintenance therapy in 2022. So there are other trials also which are under under process and will be getting results soon. So now coming to the PFS benefit with first-line PARP inhibitor maintenance therapy that has been observed across different biomarker subgroups in ovarian cancer. We have like PRIME trials, that is PRIMA, PRIME, SOLO 1, POALA 1, Athena mono trial. And this PRIMA, took niraparib versus placebo. Like if you can see in BRCA mutated tumors, HRD tumors or HR proficient tumor, all had a hazard ratio less than 1. So it was significant. Now we have again PRIME trial. Again here also we have in all the subgroups they got benefited. In SOLO 1 trial also, they only took BRCA mutated tumors where again HR hazard ratio was 0.3. So the groups are benefited. Now if you see POALA 1, we see they took olaparib plus bevacizumab as maintenance therapy versus placebo plus bevacizumab. And here, though BRCA mutated tumors and HRD tumors got benefited, our HR proficient tumor did not so much benefit with olaparib and bevacizumab. And again, then came Athena mono trial where they took head-on trial, they took rucaparib versus placebo. And again, all the subgroups they showed benefited. Like I had discussed previously also, in all these trials, BRCA mutated tumors and HRD tumors, they showed consistent benefit. But it was this HR proficient tumors where the benefit was questionable. So in this, if we see only rucaparib and niraparib, they showed consistent benefit, not in olaparib and bevacizumab group. So now this is ESMO 2024 clinical practice guideline for use of PARP inhibitor as maintenance treatment in newly diagnosed ovarian cancer. Here high-grade ovarian cancer, all were introduced into BRCA testing and HRD testing. And after they received PR or CR to first-line platinum-based chemotherapy, they were given PARP inhibitors like BRCA mutated tumors, they can be introduced into olaparib, niraparib, or olaparib and bevacizumab if bevacizumab was given initially with platinums. And again, HR deficient and BRCA wild type tumors, after partial response or complete response, can be given niraparib and olaparib plus bevacizumab and rucaparib. But in HR proficient and HRD unknown tumors, role of olaparib is questionable. Only like niraparib and rucaparib can be used, and bevacizumab can be used as maintenance if it is given as first-line therapy along with platinums. Now, to optimize patient care in ovarian cancer, multiple factors need to be considered beyond biomarker status. There can be disease characteristics, patient characteristics, drug properties, and accessibility. So in disease characteristics, we take into account clinical characteristics, which symptoms, molecular characteristics, that is biomarker status, histology, whether it is high grade or low grade, response to platinum, that is we can assess through RECIST, CRS, or KILIM. and surgical outcomes, whether like residual disease is present or not. So now coming to patient characteristics, we need to assess what was the overall treatment plan, what were the comorbidities of the patient, and what was the patient preference, whether he wants to receive IV or oral therapy. And quality of life and patient-reported outcomes are also important, and general and functional status. In drug properties, it is very important to assess safety and efficacy, ease of administration, individualized dosing, and drug-drug interaction. Again, accessibility of genetic tests like BRCA and HRD testing is very important, because even now many centers don't have, and many people also cannot afford this molecular tests. So approvals and indications of same is also important, and reimbursement and cost are always the issue in Indian scenario. So now discussing PRIMA trial. So PRIMA trial is a phase 3 randomized double-blind placebo-controlled trial of niraparib maintenance therapy in patients with newly diagnosed advanced ovarian cancer who have responded to first-line platinum-based chemotherapy. So the patients with newly diagnosed advanced ovarian cancer at high risk for recurrence after response to first-line platinum-based chemotherapy were randomized into 2:1 ratio with niraparib versus placebo. And the endpoints, the primary endpoint was PFS, and key secondary endpoint was OS. Secondary endpoints were PFS2 and TFST, PRDs, etc. So TFST, that is time to subsequent therapy. So now the stratification factors they took into account were whether NSCT was administered or not, and best response to first platinum therapy, whether patient achieved CR or PR, and tissue homologous recombination test status like HRD or HR proficient status, and chemotherapy inclusion criteria were patients should receive 6 to 9 cycles of platinum-based chemotherapy, and debulking surgery and intraperitoneal therapy are allowed. Complete and partial response to platinum-based regimen as per RECIST criteria, and either CA-125 is in normal range or CA-125 is decreased by more than 90% during the first-line therapy, stable, whether it is stable for more than 7 days or not. Now coming to statistical analysis, hierarchical testing was done, like PFS, the patients with HRD tumors followed by overall population, and OS the overall population, then patients with HRD tumors. So now evaluating the differences in patient characteristics is critical to interpret the outcomes across the PARP inhibitor studies, because this PRIMA trial, they took very high risk patients as compared to the other trial. So looking at those patient characteristics, we see the known risk factors for progression in advanced ovarian cancer, as we all know, a stage 4 disease at initial diagnosis, patient whether has received NSCT or has got debulking surgery or not is important. Whether patient has visible residual disease after surgery or not is important. BRCA wild type disease or unknown BRCA status is again important. And whether patient has achieved at least partial response to chemotherapy or not is also important. So if we see the spectrum across the all the trials, we see PRIMA has got the worst patient characteristics. PRIMA has got, if you see, the stage 4 disease was the highest at 35% as compared to the other trials, that is PAULA 1, PRIME, Athena, Mono, Solo 1, etc. So, again, visible residual disease was also highest in PRIMA trial as compared to the other trials. And neoadjuvant patient who received neoadjuvant chemotherapy was also highest with PRIMA trial. So now, again, patient who achieved PR to chemotherapy was highest, and in other trials, maybe patient have also received CR. Now coming to BRCA wild type tumors, PRIMA again has all those trials had similar patient characteristics, that is up to 60 to 70%. So PRIMA included patients with platinum responsive advanced ovarian cancer at high risk of recurrence. So now the 2/3 of patients received prior NSCT. Greater than 99% of patients with stage 3 disease had visible residual disease after primary cytotoxic surgery. Now coming to biochemical characteristics, patient had to have either CA-125 in normal range or CA-125 has to decrease by more than 90% during their frontline therapy, or stable for more than 7 days, and there should be no increase by more than 15%. Now coming to molecular characteristics, whether patient is HR deficient or BRCA mutated is important. So, and that is 30.4% was in this trial, and patient with BRCA wild type were 20.5%. The influence responses is seen in the first and subsequent lines of therapy. At 5 years, niraparib reduced the risk of disease progression or death versus placebo in intention to treat patient, HR deficient patient,
Dr.
and
Priya,
HR proficient population.
Please try to finish.
So at 6.2 year follow-up, we observe 5-year PFS rate were 22% versus 12% in intention to treat population, and 35% versus 16% in HRD population, and 8% versus 7% in HR proficient population. So it was like the HRD population which were benefited the most as compared to HR proficient population, maybe because of the worse disease characteristic that primer trial presented. So now coming to this graph, we see the quality of life is consistent with the primary analysis. Completion rate of patient reported outcomes assessment forms were high. Delaying progression is critical to maintain health related quality of life. Now coming to final overall survival analysis, it showed no difference between treatment arms in intention to treat population and HR deficient or HR proficient population. So now the Priman demonstrated a 3-fold higher and early post-progression PARP inhibitor use in patient randomized to placebo versus niraparib. So coming to subsequent PARP inhibitor use, most predominant in HRD population with highest use in HRD and BRCA mutated population. Of those who received subsequent PARP inhibitor treatment, greater than 80% of patients initiated treatment in second line setting. So now coming to long-term safety that remains consistent with up to 7 years of follow-up. The median treatment exposure was 11.3 and 8.3 months. So now this is PRIME trial, just 1 minute I'll take. So they took better patient characteristics as compared to the PRIMA trial. Here the results were better as compared to PRIMA trial. So so now summarizing the this PRIME summary, the niraparib, I'll just skip this. Again we have so now just because we are short of time, just we'll go into conclusion. So PRIMA is a positive trial that met its primary endpoint when evaluating niraparib monotherapy in first-line maintenance in patients with newly diagnosed ovarian cancer at high risk of recurrence after response to first-line platinum-based chemotherapy. So niraparib demonstrated sustained and durable observed 5-year PFS benefit at 6.2-year follow-up in HRD and intention to treat population. A totality of efficacy and safety data across the PRIMA, PRIME and real-world evidence supports the use of niraparib in HR deficient and HR proficient patients who respond to first-line platinum-based chemotherapy. So now coming to the dose forms, it comes in like 100 milligram tablet. So it is given orally. So we can give it at 200 milligram daily or 300 milligram daily. So okay, anyways, I think thank you.
Okay. Thank you, Dr. Priya, for a nice presentation. Her take-home message is that niraparib transformed ovarian cancer management by extending remission, especially in HRD positive and BRCA mutated patient, and carefully selected biomarker-driven negative patients also, they are being benefited. I think any opinion or any interactive session from the floor, otherwise we will conclude. Okay.
Thank you so much. Thank you so much.
We can hand over the mic to organizer.
Yeah, thank you, Dipti Rani ma'am, for chairing the session. We are now proceeding to the next talk. May I please call upon our chairpersons, Dr. Geeta from Ranchi. She's a surgical oncologist. Then Dr. Ajit Kushwaha, Dr. A.D. Sharma, sir. May I please call upon the next speaker, Dr. Nitesh Kumar Sinha, surgical oncologist from Jamshedpur. I may request the speakers to kindly call upon the moderator for the panel discussion.
Good morning, everyone. So the next session is panel discussion on new adjuvant and adjuvant therapy for HER2 positive breast cancer. So I'd like to call upon our moderator, Dr. Anabharshan Sekar. He is Associate Professor at LabTak Mumbai. Kindly welcome.
Good morning, everyone. I would like to welcome all my panelists for this discussion. Dr. Ghanshyam sir, Dr. Tonse, Dr. Sayak Dev, Dr. Sushma Agarwal, and Dr. Sunny Khanna, Dr. Arushi, my apologies, Arushi name is missing, Dr. Nitesh Anand. Nitesh Anand. So we have a very good mix of panel with surgical and medical oncologists and radiation oncologists, as well very experienced person and young dynamic oncologist also. I hope this discussion will be more useful in this session. Only thing is we have very limited time constraint here. 15 minutes we have to complete the discussion. So let's quickly proceed with the discussion. So first case is 22-year-old female with a strong family history. In fact, her mother had a breast cancer present with a right-sided lump, and biopsy is suggestive of HER2 positive disease, ERPR negativity, and PET scan showing non-metastatic disease, and this is her histopathological finding. My question to Dr. Tonse is, when do you consider genetic testing in HER2 positive patient? How often you experience this situation?
It's extremely rare that you get, BRCA positivity in a HER2 positive breast cancer. If there is a strong family history, like first degree relative having breast cancer or ovarian cancer, or 2 or more first degree relatives or extended relatives having breast or ovarian cancer, or breast cancer after the age of 60 in the same family, also we should have a high index of suspicion and send for an entire panel of HBOC in this kind, and a family history of male breast cancer and aggressive prostate cancer in the family, and pancreatic cancer. These are other things to look for, and colon cancer as well. Certain history we need to
Yes,
look
sir.
for.
Sir, Anshul, sir. Yes.
So the guidelines don't recommend for a HER2 positive, but if you pull out, because 2 subsequent patients of mine, even not younger age group, they turned out to be a BRCA positive. Then I looked at the literature. So literature showed that HR positive disease will have 10% of BRCA.
Okay.
And if you look at HER2 positive, that cohort in that study showed that so around 5 to 10% of HER2 positive also carries, irrespective of family history or not. So though we undermine the HER2 positive patients and BRCA, but still from the literature 5 to 10% of them will have an either BRCA1 or BRCA2.
Sure. Thank you, sir. So this is small insight about HER2 positive breast cancer, because most of the time when it comes to genetic testing, it is synonymous with either hormone positive or TNBC setting. But when we look into the HER2 positive setting also, there is a reasonable data to suggest you need to consider genetic testing, especially when the patient is young female and having a strong family history. And what is the most common mutation in this population is Leaf-Romani syndrome. There is higher propensity for TP53 mutation. And also, if we dissect it out other way, if we dissect it out patients who are having Leaf-Romani syndrome, even in those patients, the most common type of breast cancer is HER2 positive breast cancer. So in either way, you need to look for this thing in this situation, and also you need to look for BRCA positivity. This is again one more systemic review and meta-analysis, which is highlighting that there are 8 different kind of germline panel they have tested, gene mutation panel they have tested, among which in the top 3, CHEK2, ATM, TP53, these are the 3 different mutation which is common in HER2 positive breast cancer. Rest other like BRCA, PALB2 and BRAD1 are more common in TNBC or hormone positive setting. So quickly move on to next question. What is considered as upfront surgery? Because this patient is having a 3 centimeter tumor, lymph node positive. If suppose the patient is having lymph node negative and 3 centimeter, what will be your option, my surgeon, the panelist?
So given a high risk disease and young age of the female and more than 2 centimeter size tumor, I would likely to go for a neoadjuvant therapy in these patients. And before that, I would like to, because there's a possibility of a Leaf-Romani syndrome or a genetic thing, So in this case, I would, because the node is positive, one node I would like to clip so that in the subsequent post-neoadjuvant, I can plan for a SLN or a TAD. And I will also like to send the patient for a fertility counseling because she is a young patient.
Thank you. So that is a very good thought process to bring in fertility counseling also in this patient. My next question is, who all agree with that every surgeon is going with more than 2 centimeter, they're referring for chemo, or any other different guidelines or opinion in this situation? Saik, your opinion?
So mine is that if the patient, the tumor size is clinically less than 2 centimeter and non-negative, she can undergo an upfront.
No, it's not about your experience. I'm just asking whether your surgeon is referring it to you when the patient tumor size is more than 2 centimeter or not.
No, if the tumor is more than 2, then I will go for NCT only.
Okay, so for us in Tata, it is a very tricky situation. We don't, even though the guidelines are recommending more than 2 centimeter, still we have surgeons referring only when the patient is either node positive or the tumor size is more than 3 centimeter. And
if the patient is very comorbid, aged, then we can go for every
And till the last WCA data we have analyzed, till that point in time, there was a very strong debate. You know why you want to go for neoadjuvant treatment? What is the advantage of neoadjuvant? None of the treatment, none of the systemic review or meta-analysis has not shown advantage with neoadjuvant. So why you want to subject the patient to neoadjuvant? This is one important study published by Dr. Sudeep Gupta sir and our team, which is highlighting 3 important factors in this situation. PCR is one of the robust factor for detecting both PFS as well as EFS in this situation. And second important thing is baseline clinical staging. If the patient is having higher T stage and a higher end stage, they are having higher propensity for developing further relapse and subsequent disease in the situation. And third important factor is standard trastuzumab. So there were a lot of debates happening whether you want to give short duration trastuzumab or not. Again, this study is highlighting yet another important factor. 1 year of trastuzumab is needed in this patient. Sir, next question to Ghansham sir. What is your journey with regarding to trastuzumab? How you find trastuzumab? You are in the era where trastuzumab is not available. Now you are having plenty of other anti-HER2 therapies also available in this situation. What is your experience and how?
So I was the first student, registered DM student of Advani sir.
Yes.
So that was year 2000, 2001, and so we did not have trastuzumab. So probably the first Rose trastuzumab came in 2002, 2003. So that time the cost of per vial was 1,35,000. So 1,35,000, and same year rituximab came for a 600 milligram. It was costing 1.15 lakhs. And we published the first paper also as a resident rituximab in the whole country experience. And now, so you can know, so you can get the same trastuzumab at 10,000 rupees. So these 23 years journey, and probably the whole effort of getting first targeted therapy in the breast cancer space in terms of HER2. So definitely had to see change the survival, and now we have come a long way in regards to that.
So I think I totally agree. You know, this treatment has changed a very significant impact in this patient. In fact, the first case I have discussed, this patient diagnosed in 2015 and she received trastuzumab. Close to 10 years, even with Lee-Fraunhofer syndrome, she managed. In between, she had so many cancers in between, but still the impact of first treatment is more crucial, and receiving trastuzumab changed her life in this patient. For all the audience in the all the audience, I would like to go through this paper. This article is beautifully summarizing the 20 years journey of trastuzumab in the situation. They are giving each and every article, and you know, most important factor is they are discussing about the resistant patterns with trastuzumab also. I think it's a good to go in Saturday discussion. And next, my question is to Dr. Arushi. If the patient with Lee-Fraunhofer syndrome, will it change your management in radiation in this situation?
Yes, sir, definitely, because in Lee-Fraunhofer, we usually avoid giving radiation because the patient obviously has chances of secondary malignancies. So it's an absolute contraindication in our cases. However, if there are instances where the patient was not fit for complete mastectomy, and there are no other options that we can offer the patient, then we really have to take the risk of giving radiation by explaining the patient the chances of second malignancy, and of course we also give them an opportunity that proton can also be offered in such patients.
So actually we don't have data for proton. We were discussing for it, but we should avoid radiation in patients who are having high risk for cancer. You know, these patients are more propensity for sarcomas also. So that is one thing we should consider. And from trastuzumab, it's like now only we have access for most of our patients for trastuzumab, but the guidelines has entirely changed out. You know, we have the guidelines first giving dual anti-HER2 therapy. Now we are on a discussion to add anti-ADC into the picture in neoadjuvant as well as adjuvant setting. This is with regarding the overall summary, what will happen during the course of time. So another interesting factor is high risk criteria is changing. We seen this with hormone positive breast cancer also. When Monarch come, then Natalie come, the high risk criteria has been changed. And again, this situation is changing. Sayak, would you like to take this question? What is high risk as per Destiny?
So according to the Destiny 5 trial, which had studied the role of adjuvant TDXD, so the high risk is that any inoperable breast cancer, that is T4 disease, or any operable breast cancer with N2 or N3 disease. And in case of operable breast cancer, they should have after chemotherapy and target therapy, there should be a residual disease with at least YP N2 N3 disease. So that is the definition for high risk.
Yes. So one thing to note down here is Destiny 5 and Destiny 11 having different high risk definition. When you give a neoadjuvant setting, they have not considered tumor less than 5 centimeter if node is negative. That is to keep it very simple. If it is an adjuvant setting, they have taken predominantly any node positive after neoadjuvant therapy. And second important thing is baseline risk factor. If the baseline risk factor patient is having T3 or T4 disease with N2 and N3 onwards, they are taking the patient into the study. So this is with regarding different high risk criteria for different studies like Trifana, Neosphere, all those things. And it is Destiny 11 is slightly different from those studies. And we all know that Destiny 11 has a breakthrough in last year 2025 ASCO. They have published the data showing good amount of impact in PATCR. And the major impact is seen in hormone receptor negative HER2 positive patient. And this is how the result is standing out in this situation. So any thought processor, anyone want to include Destiny 11 into the practice as of now, because it has now FDA approval also in this situation?
So any patient who fits into the criteria for high risk, including HR positive disease. So HR positive disease had a low pathological CR. So normally HR negative, HER2 positive will have, with the TCHP will have something around 60-65%. But if you look at the hormone negative, so they will have less than 50%. So probably, so that also probably will be clinically included, so that you get a path CR of around 80-84% with the TDXD combination, so that minimal residual disease gets lessened and probably you get better survival. So probably the high risk as of now, because high risk patients can be offered this regimen.
Dr. Nitish, your opinion, you are planning to include TDXD in your practice, either in adjuvant or neoadjuvant setting as of now?
Sir, only on those young and fit patients who will be, I think, we accept those toxicities. The toxicity profile of TDXD is much more severe compared to any of the combination of anti-HER2 therapies.
So,
I would like to differ actually. The hematological toxicity of Enhertu is actually less compared to the traditional TCHP what we give, or AC followed by, because of the neutropenia, thrombocytopenia, we require multiple dose modification. Only concern is ILD, but in the neoadjuvant setting, the incidence of ILD was not high because the number of doses of Enhertu offered was less, 3 cycles only, whereas in the adjuvant setting, that is DB11 data, which showed higher ILD rates because you're giving for a longer period of time, so incidence to the tune of close to 10%. So there is the concern. In the NACD, I think it's a very doable option. We must offer to our patients. We can give it to a frail patient as well. This DXD Enhertu, very well tolerated. The incidence of CINV is lesser as opposed to anthracycline or AUC carboplatin 5 or 6 when you offer. Just you need to be careful. Patient education with respect to ILD symptoms, documentation of saturations, and doing an HRCT at baseline and doing it every third cycle of every 9 to 12 weeks is very important. Yeah.
Thank you. Dr. Sushma ma'am, your opinion regarding radiation in these patients. You know, now we are having access to newer target therapies, which has to be incorporated in either neoadjuvant or adjuvant setting. There you are comfortable in giving radiation concurrently with newer drugs like TDXD or TDM1. What is your experience with this?
No, I don't have any experience. I have experience of giving trastuzumab, but obviously these newer ADCs have just come, so we don't have experience because of its cost. So, but But I would be a bit wary. I would be a bit skeptical. Concurrent, I would not give along with ADCs.
Even with TDM1?
TDM1, there is no data as much as
TDM we can give concurrent.
Concurrently, okay.
Yeah,
I am aware of trastuzumab that we can give.
So
this year ASCO only they have published the red, green, yellow.
Yes.
So probably, so no cytotoxics, so no olaparib, no capecitabine with concurrent chemotherapy, concurrent radiation, rest all can be given.
Yes. So, and even in the Destiny 5, what they have done is, there are certain patients who are taken sequential RT, certain patients they have taken concurrent RT. Both the options are available, but only thing is, my suggestion is, let's wait for the long-term data. Both these trials yet to publish a long-term data, even though I'm more intended for adjuvant setting because that data is more promising. They have taken truly high-risk patients when they failed with neoadjuvant treatment. But we should also consider long-term data before starting or changing our practice in this situation. I think second case I will little bit summarize. So in Indian situation, we often encounter some patients with mediastinal lymph nodes with locally advanced disease. So any role of bronchoscopy or any further invasive investigation in the population, so I would like to take surgeon in this question. So do you encounter such situation in your practice routinely?
In this case, actually, we have a sternal mets also, and we have mediastinal mets also. In case sternal is more accessible for a biopsy. In case the sternal mets is not there, then we can go for a EBUS, TBNA in these cases.
So if the patient is having mediastinal nodes, what your opinion on bronchoscopy?
Yes, I would like to go for a biopsy.
So yes, you should consider, you know, sometimes our Indian patients are more prone to for tuberculosis and other granulomatous diseases. So if the patient is having no other metastatic disease elsewhere, then it is definitely worthwhile doing bronchoscopy in this patient. In the interest of time, I would like to wind up the session over here. So thank you all my panelists. Thanks everyone. Thank you.
Thank you, Dr. Shekhar. And for the next session, I would like to invite So thank you, Dr. Shekhar, for such a wonderful discussion. And for the next session, I'd like to invite. For the next session, I'd like to invite Dr. Joydeep Ghosh for the panel discussion on identifying and managing the high-risk HER2 positive and HR positive and HER2 negative, node positive, early and metastatic breast cancer. Dr. Joydeep Ghosh.
Should I start? Okay. Okay. So I would like to call upon my panelists, Dr. Tonse and Dr. Sushant Paikre. It's not moving here. It's moving here. So we'll discuss about node positive, hormone receptor positive group in the adjuvant setting, so which we actually consider as high risk. So if we begin with Dr. Paikre, so do all node positive patients in the hormone receptor early breast cancer have the same risk of recurrence? What is your take on that?
That depends upon how much node is positive. So definitely there is N1, N2, N3 disease at different survival rate.
Yeah.
And also number also matters. Less than 4, more than 4 also have different survival.
Right. So as we can see clearly in this in the survival curves that those who have a node positive high risk, that means 1 to 3 lymph nodes which are grade 3 or tumor size more than 5 centimeter, you can see that their relapse rates are actually higher than early TNBCs. We are always scared of TNBCs, but we are not, most of the times we are unable to address the elephant in the room, which is basically a high risk hormone receptor positive disease, which has a poor prognosis. And also, if you look at the N1 high risk versus N1 non-high risk, that is the N1 patients who have the high risk factors versus who don't have the high risk factors, there is a significant difference in the 5-year recurrence rate, which is almost 14%. So there is a wide gap that we need to address to reduce this recurrence in these patients. So let us first take this case, 51-year-old postmenopausal, screening detected CA breast, surgery was done, good postoperative recovery, pathology shows a T2 disease, 2.1 centimeter, 2 lymph nodes, grade 3, ERPR positive, HER2 negative, so it's PT2N1 stage 2B. Molecular profiling to assess MDT was given, molecular profiling was done to assess, and Ki67 was 25 to 30%. Now, Ki67 probably has lost its role in deciding treatment, but yes, it is definitely predictive of the long-term outcomes. We can see that the curves shift downwards whenever the Ki67 is high. And also in the monarch, if we look at the monarch data, the patients who had a higher, who had a low risk or who had a high risk, both of them actually favored the usage of abemaciclib plus endocrine therapy, especially if they had a high risk morphology. So, Dr. Tonse, do you normally take the help of your oncotype score or genomic score? I know it is not meant for CDK4/6, it is meant for chemotherapy, but do you use that score to decide your CDK4/6 also in your patients?
Yes, especially when we look at the grade of the tumor here, grade 3 tumor, aggressive disease. And there is some data from ribociclib also, where they have used genomic profiling to look for who are patients with high risk of recurrence, which you can replicate it for adjuvant abemaciclib as well. And she fits into that. Though she is N1 disease, she has grade 3 tumor, and probably her oncotype DX was showing high risk. These are the patients who benefit with adjuvant CDK4/6 inhibitors more than others.
So if you look at the trial overview of both the two important drugs, that's the Monarchy and the Natalie, the Monarchy included a very specific group of patients, which is more than 4 nodes positive, or if they are N1, if they had any of the high risk features like the grade 3 or tumor size more than 5, and a histological rate of 3+ with tumor size more than 5. And also the treatment duration was for 2 years. Dosing was 150 milligram continuous dosing, and endocrine therapy was as per physician's choice. So it can be either AI or tamoxifen. So coming to Dr. Sushant, so what is your view on the 7-year data of IDFS benefit that we have with this thing? Is it practicing enough, or practice changing enough, or is it convincing enough?
Yeah, that is whenever in clinically also, in my practice also, whenever I find that criteria meets this trial, then I likely to give that Ramiven because of this thing. Because after giving 2 years also, the curves remain separated and separated. I also want to know what is the 10-year also wait. And another thing, every year they are giving the data of 4-year. Initially they gave the 4-year, then now it is 5, 6 years, now 7 years. So gradually the difference was increasing. So I very much convincing with this data of benefit of abemaciclib.
Yes, you're right. See, if you look at the number at risk in the lower panel, so there are, I mean, all the events have already happened. So even with a long-term follow-up, it's unlikely that curves are going to converge on each other. So they'll keep on, staying separate. So that is very convincing for all of us. We have almost a 28% reduction in the risk of recurrence with a favorable hazard ratio of 0.7. Also, if you look at the ability to reduce the risk of recurrence to incurable metastatic disease, that is also like, so reduction in the distant relapse, that has also improved almost 5 percentage points with the addition of abemaciclib. And it is the only CDK inhibitor with a proven overall benefit, survival benefit in the curative setting and 2 years of treatment. So it is, as of now, we have the mature data of this study where we have a 7-year data that there is a OS increment of around 2%. So Dr. Tonse, do you, are you comfortable with using a drug which has an OS benefit of 2% in the curative setting in the long term? What is your take on that?
See, to prove a overall survival benefit in an adjuvant setting in a hormone-positive breast cancer, it probably would take decades.
Yes,
so I think IDFS benefit will weigh in here, because once you have recurrence, you don't know in what way they are going to behave. They are going to probably have a receptor transformation too.
Right.
So why not give them the benefit in the adjuvant setting and try and prevent a relapse, which could be lethal.
Absolutely, I completely agree with you, and it is very difficult to prove an OS benefit.
Along with
Yes.
the OS benefit, they have also benefit of if you are adding other marker factors like IDFS, it is very much significant. Also, it's decrease the distant relapse also. That also helps us to maintain the quality of life.
Yes.
Another thing, the hormone positive cancers they have long-term survival, and they have long relapse rate also.
Right.
So I want to know whether in 10 years, if it is more than 5%, then definitely this is the choice in overall survival for us.
Absolutely. What the point I want to make is that overall survival in such an early disease should not be the only criteria to assess, because we have critics falling on us that, oh, there is 2% OS benefit, how are you justifying the use? All these patients have multiple successful subsequent therapies if they relapse, so it's very difficult to have a clear-cut OS benefit. But as mentioned by both my panelists, that IDFS is a very good surrogate marker in this situation. So if we take this concept of how common the need for adjuvant therapy in our patients, now we have some Indian data. So Dr. Tonse, in your practice, what percentage of patients need this in the hormone receptor positive, and how many of them actually get that?
I think 60 to 70% probably are candidates for adjuvant CDK4/6 inhibitors, but I think less than 20% patients are able to afford it or take it, because generally most of these ER/PR positive, HER2 negative patients are women who are elderly, frail, 75 and above, or they are not financially fit enough. So only I think less than 20% patients are able to take the CDK4/6 inhibitors.
Right. So that is discouraging for all of us, because we have a treatment which is available, but due to various factors, we are unable to give it to a large chunk of patients who actually deserve this treatment. So regarding coming to dose reduction, Sushant, so these are the normal, adverse events which we are all aware of, diarrhea and all those things. And also there is the data that dose reduction does not actually affect the long-term outcomes. We've seen this with Palbo, we've seen this with Abema. So in your practice, do you have to deal with the side effects significantly, or it's not much of an issue?
Currently, I have 10 patients on abemaciclib for adjuvant settings. But one thing I pointed out, that our patient, Indian, that patient, they are not having typical diarrhea. They complaining of about fatigue.
Okay.
Very much.
Yeah.
So in that case, I just interrupt few days, did not reduce the dose, and when restarted after 2 to 3 months, they adapted with that, no fatigue after that, after 3 months.
Right.
So most of patients are complaining about fatigue, not diarrhea.
Yeah, so they get to learn to stay with the fatigue or do something which improves the fatigue. That is a very common thing. And also you can see that if you look at the dose, full dose versus lower dose, the hazard ratio is exactly nearly 1. So we don't have to actually worry, even if the patient has a diarrhea or a severe fatigue which they are unable to manage, and we are reducing the dose, we should assure our patients with this data that there is adequately nothing to worry when it comes to efficacy. Now coming to the guidelines, Dr. Tonse. So we have clear-cut guidelines abemaciclib, both are green. Evidence quality is high and the strength is very strong. And Natalie yet to mature. So what if you are to select between abema versus ribo for the same particular patient, would you go to the guidelines? What would you do?
Yeah, I mean, yes, the guidelines strongly favor towards abemaciclib because of the longer data, the 7-year data what we have. And another thing is, interestingly, we here give only for 2 years. It's not like 3 years of duration of therapy. It depends. If my patient is younger, fitter, and I have faced certain difficulties like diarrhea with abema. So then for a frail patient, I would go for ribo. For somebody who's younger, fitter, then I consider abemaciclib.
You're thinking mostly from the side effect
Yeah,
perspective?
diarrhea, because I have faced grade 3 diarrhea as well.
Okay, okay, understood. Fair enough. So coming to the other group, so basically, suppose in the below mentioned case scenario, what would be their first line treatment? So 45-year-old, treated breast cancer, completed adjuvant AI, 5 years after completion has now visceral disease. So Sushant, what would be your go-to regimen here?
Yeah, definitely, if patient having visceral disease, my
Right.
choice would be CDK4/6 inhibitor.
Right.
That I would follow the Monarch trial and Mona Lisa trial.
Right.
And these both are, I have choice. Depending upon affordability, I will use that.
Right.
Definitely, if patient having brain mets, or in that case, will use abema because good CNS penetration.
Perfect. And suppose we have a 50-year-old female who started on AI and the adjuvant and has progressed within 1.5 years. So in this situation, what would be your strategy, Dr. Tonse?
I would like to biopsy this patient.
Biopsy this
Yeah,
patient. Perfect.
and
Absolutely.
if she still remains hormone positive, I would like to send an NGS, ESR1
Yes,
and other mutation. Also, depending on whether she seems to be something like primary endocrine refractory disease.
Right.
Here, probably I would opt for fulvestrant with a CDK4/6 inhibitor if she's strongly, and if she's ESR alpha mutated, I have no personal experience of elasticin, but would like to explore that option if she can afford it.
We should also look at the PIK3 and all
PIK3
those.
and other
Yes,
mutations.
completely agree. So, of course, if we don't have any of these evolving mutations, as Dr. Tonse has suggested, the go-to treatment would be a CDK4 plus a fulvestrant, and of course, we have the data with Ramiven. So this is our summary slide. Definitely, the risk of recurrence reduces significantly in the clear-cut high-risk group, node positive. And we have data with both AI as well as tamoxifen. So even if we have a premenopausal patient, it doesn't matter. You not necessarily have to use a GnRH. And dose reduction, of course, is required in many patients, and we need not worry about it because it does not affect the long-term outcomes. And in the metastatic setting, of course, it is one of the choice. I won't say the only choice, but of course, but it is one of the choice when we discuss the side effect profile and everything with the patient in both the endocrine sensitive as well as the endocrine resistant population. So with that, I wish to conclude. Thank you both my panelists for the wonderful participation.
Thank you. Thank you, moderator and panelists, for such a wonderful discussion.
Thank you, sir. Just request you to have a photo session, please. Doctor, request you to have a photo session. Thanks to the moderator and the panelist for the excellent session. Moving forward, I would like to thank the chairpersons who has chaired the session and would like to invite the next chairperson to chair the session on the days, Dr. Usha Nath, Dr. Rekha Debuka, Dr. Suman Sinha, Dr. Sunita Jha, Dr. Namrata Mahansariya, Dr. Roshan V. Khanande, For chairing the next session,
Good afternoon, everyone. We welcome you to this prestigious session by none other than our Advani sir. Sir needs no introduction, but for the sake of audience, he is a Director, Department of Medical Oncology at Jaslok Hospital and Research Center, Mumbai. And we will be benefited by him on his talk on paradigm shift in the management of CA, endometrium and cervix. Welcome, sir.
Dr. Durrani, this is really an honor to be chairing your session. It's nice to meet you actually again. Okay, thank you.
Respected Hello. Hello. Yeah. Respected chairpersons and colleagues, again, I really feel very happy to see all of you sitting here since yesterday. Many of you were there yesterday as well as today, and so attentive with a pin drop silence. I think that's what speaks the volume about all of you who are earning to learn more and more. And in medicine particularly, the learning is the most important thing. Even after 50 years of my practice in oncology, I feel that there's a lot to learn. And every day I'm learning. And that's what really keeps you alive. Otherwise it becomes a dead branch. The branch is alive because there are so many changes occurring. The science is changing. The basic knowledge is improving. And that's how we are improving in our application. As you will see, the endometrial carcinoma is one of the carcinoma. 10 years ago, it was relatively rare. We used to see endometrial carcinoma, of course, but very rarely. Our knowledge about the endometrial carcinoma was rudimentary, and it did not really give us a clear-cut prognostic implication. That is what has really changed now. Totally, it has changed. And recently, the advances which have occurred, particularly at a molecular level understanding, has changed the outlook towards this endometrial carcinoma. As you can see over here, all over, whether it's US, Europe, and India, the endometrial carcinoma is rapidly increasing in incidence. The basic reason for the increase has been the obesity. Look at the US, they are the most obese people. When you go to US, you will find everybody, ladies to males, they are eating big meals. And when you see them eating, you wonder that they eat what we can eat, 3 of us can eat. That's the amount they go on eating. And I was in the lab some time ago over there, and there were a lot of colleagues, American colleagues over there, and every 1 hourly they will go out and bring in a cake, a pastry, or something to eat. And they are working hard, but they are also eating very well. And therefore, you will find the obesity the main problem. And that's the reason why the endometrial carcinoma is increasing, particularly in the cities in India also. Now, up till now, the classification of the endometrial carcinoma was clinically oriented. It was not really much focused on the decision making. So the fact that we have to discuss about it is because of the fact that there's a rising incidence. Young patients are increasing also with this, and there's a shift to the molecular driven care. Today, without molecular classification, it is not possible to treat these patients. So that means molecular changes have become an integral part of the investigations. I remember the days long back when pathologists used to tell us this is this, and we used to accept it. Today we can't accept. The pathologist just tells me that this is a endometrial carcinoma. I'm not happy with that report. I need something more. They should give the immunohistochemistry P53 is positive or negative. That's a must. They should tell us, even in the endometrial carcinoma, whether it's a estrogen receptor, progesterone receptor, positive or negative. What does this mean? This means that pathologists have to understand the clinicians as well. The clinicians want to have more and more insight into the endometrial carcinoma. Why they want to have? Because that's where they can decide the proper, what we call it, optimum treatment. You don't want to overtreat, but you don't want to undertreat as well. So I think for the optimum treatment strategies, we need to have the details of the pathology. So I think nowadays there's a trend, which I can see yesterday also, today also, that how the pathologists are participating also in the clinical meeting. And when we have the board meeting of gynec oncology, we always have the pathologist as a main part of the whole effect. So I think this is very important, that pathologists should play an important role. And I always claim that if my pathologist is wrong, I will be wrong. Absolutely correct for many diseases, not only endometrial carcinoma. So I have to make sure that I get correct information from the pathologist. And therefore, as a clinician, I have a real liking for the pathologist. I always discuss with them, this is what is it, what it can be, how you can help us further to give us the proper diagnosis. So you can see that previously our traditional classification was endometrioid estrogen related and non-endometrioid aggressive disease. That was a real sort of a classification, and it changed. The limitation of this was, why it changed? Because the limitation. The poor risk stratification was not clearly defined. Variable outcome was there, and there was a need for the better prognostic model. And that's where the new classification came up at the molecular level. And you can see that some of the genes which are involved, one of the genes here you can see significantly 4 defects. One is a pole mutation or ultra mutation of the pole. Pole is a gene which genetically repairs the newly generated DNA. And in the absence of the pole, it's an epsilon kinase. And epsilon kinase, in the absence of that, the defect in the instability of the DNA increases. and therefore the mutation, when mutation occurs, this thing gets corrected. And that's the reason the patients who have the pole mutation, they don't seem to recur. In fact, if the pole mutation is positive, you don't have to treat the patient with the endometrioid carcinoma. It remains almost a straight line in terms of the survival. That's the importance of understanding this. Time and again I have seen many patients where we have kept these patients under observation. And when they go out somewhere, some of the doctors tell them, how come you have got the diagnosis of endometrial carcinoma, but you have not received any treatment? You cannot survive like this. But it's basically because we were confident that there is a pole mutation and therefore they don't need the further treatment. Another important thing in endometrial carcinoma, which is also important in many other diseases, is what we call it mismatch repair gene. All of us have in every cell a mismatch repair gene. So whatever the DNA defect is there, it is repaired by the enzyme which is present. What happens if this enzyme, the mismatch repair enzyme, is defective? When it is defective, the repair does not occur, and therefore microsatellite instability occurs. And lot of mutated genes go on accumulating. They accumulate so much inside the cell that the cell becomes abnormal in the sense that it has got lot of abnormal genes on the surface, the protein on the surface. When you have abnormal protein on the cell surface, it stimulates the body, and therefore it is a most immunogenic cells. So any cell which is where there is a MMR deficiency, the cells are highly immunogenic, and therefore what is the treatment of the MMR repair gene deficiency? The treatment is give immunotherapy. You give immunotherapy, the cells are highly immunogenic already, and the immunotherapy really destroys them completely. As a single agent, immunotherapy can cure majority of these patients, whether it's endometrial carcinoma, rectal carcinoma, and many other carcinomas which we are finding nowadays. And this is what we call it MSI high, microsatellite incidence high. So whenever it is high, cells are immunogenic, and with the immunotherapy they die. So that's a second important thing, which means that if you have not classified these patients, and if you have not done MSI, you would have missed it. And what you would have done, you would have given them a chemotherapy. The response to chemotherapy is close to 10% only. So look at the injustice that we would have done to a patient if we had not done the MSI. And that's what we were certainly doing it. 10 years ago, all these patients, we were not doing the MSI routinely, and therefore we were treating them with chemotherapy, and they used to die. So nowadays the pathologist will always write to us MSI high or stable by doing the immunohistochemistry, where there are 4 genes which are involved in this. They can identify them by the immunohistochemistry. So look at it, how the changing classification is demanding the pathologist to give us a better information. Then comes another classification, which is a P53 gene, aberrant gene. P53, when it is mutated, it allows the multiple tumor to occur. You just now heard Law-Frommeny syndrome, where the patient gets lot of tumor, not only breast tumors, but all types of the tumor in the body. And because P53 gene is defective. And therefore, again, whenever in endometrial carcinoma, P53 gene is mutated, It's a highly aggressive tumor and requires the most aggressive treatment. In between, intermediate grade, is the non-specific molecular profile endometrial carcinoma. We call it NSMP, which is in between. The prognosis is in between. So you can see that how we are classifying the all endometrial carcinoma right from the first whole sequencing and then MMR and then the other genes which are evaluated. So now with this sort of classification, basically we group them into the 4 types. And all these 4 types have a specific prognosis. The pole mutated have an excellent prognosis. The deficient MMR also immunotherapy benefits are phenomenal. P53 is an aggressive disease, needs everything under the earth to really control the disease. And non-specific molecular profile carries the intermediate grade, but needs the full treatment. You can see over here in terms of the survival, that those people who have a pole mutation, look at it, it's almost straight line without treatment. That's the important thing. So you can see, leave such patients without treatment. Similarly, P53 has a poor prognosis, but with the treatment, it can improve the prognosis. The deficient MMR has a real good prognosis with the immunotherapy, and copy number low has an intermediate prognosis. So based on these facts, nowadays we divide the patient, one on the basis of the molecular subtype, but second, which is also important, is the stage and the grade of the disease, and lymphovascular invasion. All these things play an important role. So remember, pathologists have to tell us not only the molecular aspect, but they have to also tell us about the grade and also the lymphovascular invasion. And of course the stage, in all such cases, normally we do all radiological imaging to really get a perfect stage of the disease. So if the patient has got the low grade, 1A observation is sufficient. Probably these are the ones which are associated with the whole mutation. If you have the intermediate risk, radiotherapy becomes essential. You can treat them in a localized disease alone with the radiotherapy alone. External and internal radiotherapy. High risk, of course, need everything, whatever you can give. The most aggressive approach in the chemotherapy, the radiotherapy, and nowadays I'll come to it, that how immunotherapy also plays an important role in this condition. So pathologists can be able to tell us all these molecular defects nicely. Apart from this, we also have something, the surface, abnormal surface expression of the HER2 molecule. Some of these patients, endometrial carcinoma, have HER2 expression, overexpression, and therefore they not only need whatever other treatment you are giving, but they also need trastuzumab. And I think that is what that's how we can improve the survival by adding the trastuzumab. And I must tell you that now for all these HER2 positive diseases, apart from the breast, what it is being recommended is the N-HER2. Some time ago we were discussing that in breast cancer also upfront N-HER2 has come up already. But in all these situations where the HER2 is positive, N-HER2 is strongly being recommended as a treatment because it increases the cure rate. And the treatment, I already told you that how the immunotherapy works. This is very important to understand. Those of you who were present yesterday, this may be little repetition, but I think it's very important to understand what is this immunotherapy we are talking about. Immunotherapy is not a immunotherapy of olden days. In olden days, we used to use the BCG, polyvalent bacterial antigen, inject and hope that it will stimulate the body immunity. What it used to do is it stimulates the B cells, and B cells used to get stimulated and it produces antibodies which are not worth the treatment for the cancer. For cancer, you need the T cells, which is important. The center point of the immunotherapy in the cancer is the T cells. So you look at it, what happens in the body. The tumor antigens get shedded from the wherever they are present in the cells, and it is taken over by the antigen recognizing cells, and then it makes the neoantigen, and that neoantigen stimulates the naive T cells, the T cells which are not exposed to the antigen. It stimulates it, it gets further activated, and we call it activated T cells. They get really express lot of surface molecules and which go and kill the tumor cells. This is what really happens in the body, that the T cells get activated and ultimately kill the tumor cells. But in the body, there is always auto-regulation. This is to be remembered very carefully. So what happens after some time or during this process, the T cells start expressing some molecules which prevent the activation of the T cells. So at the effector phase, there is a molecule which gets generated from the T cells. What it does is, that is called the programmed death protein, PD1 or PDL1, ligand L1. So that is generated, and that generated molecule, it prevents the T cells from activation. This is what happens in the body, and for any immune stimulation, this is a must. Body has kept the God has kept, I think, the auto-regulation, because if we allow the T cells to be stimulated, and stimulated, they will ultimately produce the autoimmune disease. That's what happens really in majority of the autoimmune disease, where the auto-regulation is defective. So in auto-regulation, PDL1 plays PD1 plays an important role. At the initial phase, in the naive T cells are getting stimulated, there is also another protein which is secreted by the T cells. We call it cytotoxic lymphocyte antigen 4, and that also prevents the activation of the T cells. So look at it. We have activated T cells, we have inhibitory molecules which inhibits the T cells and keep up the balance. This is what happens in the body. Now when we are talking about immunotherapy, the way to induce more immunotherapy against the tumor cell is to stimulate the T cells more. But there is a limit. You cannot stimulate the T cells more. And therefore what you do is, the break which is occurring in terms of the PD1 or the CTLA4, you remove them. You remove the brake, the car will run faster and forever. It stops only when you give the brake. So if you remove the brake, you have achieved whatever you wanted to do. So what people have done is, recognizing this basis of the immune system, they have got the antibodies against PD1. That is what we call it immunotherapy. So in fact, it's not a immunotherapy. It's not the sense that it stimulates the cells, but it actually counteracts the inhibitory pathway of the T cells. So it stops the PD1 action, and therefore there is no inhibition. T cells will go on killing the tumor cells. Same way, the cytotoxic T lymphocyte antigen, if you nullify it with a monoclonal antibodies, again the activation of the T cells will go on and on and on. This is what really happened. So the immunotherapy of the modern medicine is totally different from the immunotherapy of the olden days, and that's how it really works very well. And we have a large number of the drugs which act on the PD-1 like Pembro, Dostarlimab, and they are also, these drugs are also show high response to MSI, high tumors. And I told you the reason why MSI high tumors respond well to the immunotherapy, because they are, tumor cells themselves are highly immunogenic because of the accumulation of the microsatellite unstable genes. Here you can see now the data. You can see that how in deficient mismatch repair gene, you with the placebo, the long-term survival is poor. But if you give only the immunotherapy, you can see it improves to 60%, and this is a 60% cure rate. Mind you, in deficient MMR, the cure rate is very high. Similarly, you look at the other graph where the chemotherapy along with the immunotherapy shows a better result as compared to the chemotherapy alone. And you look at the down graphs. All of them will show you that immunotherapy of different types, whether it's atezolizumab, durvalumab, all of them work very nicely. So this is what happens really in the deficient MMR or MSI high, that the prognosis really get improved. Now the question is always whether we should use the immunotherapy for all patients. All the patients are not deficient MMR. There are some majority of the patients are what we call it proficient MMR. That means they have a normal MMR gene, MMR repair gene. They are normal. Even then the immunotherapy seems to show the response. Look at it with the using the, in the proficient cases, we can really get the better results. And of course, we can combine it with the other tyrosine kinase inhibitors, and again it becomes effective. Whenever we call it MSI high, that means MMR gene defect, the question comes up of the Lynch syndrome, which is a syndrome where there's a mismatch repair gene is defective, it is inherited as a dominant gene, and all the children will get this thing. And therefore, in such a case, the recurrent disease is also more common. So I feel that what we have learned today is that endometrial carcinoma is a new entity in terms of better understanding. And it's not only better understanding, but also it's a better outcome based on the specific treatment that we can give to them, to these people. I think that's really important. The molecular classification drives the management. Immunotherapy is transformative both for the deficient MMR as well as the proficient MMR, and precision oncology is the future. So that's what we really sort of give the thing. I think the time is over. Thank you very much, and we have really
Thank you, sir. Thank you for your excellent talk. And thank you so much for enriching us with your knowledge of paradigm shift in the management of CA, endometrial and cervic cancer. I would like to request the chairperson to be seated and would request Dr. Satish Sharma, sir, to join us on this dais. So here we have gathered for the launch of a magazine, पलाश की उम्मीद, उम्मीद साहस और जीवन की नई शुरुआत. And I would like to invite for Dr. Atul Sharma, Chairman Medical Oncology at Max Hospital, Saket, to join us on the dais. Dr. Tejinder Kataria ma'am, Chairperson Radiation Oncology at Medanta, Gurugram, to please join us for the launch of magazine. Thank you, ma'am. Mr. Syed Ansari, Executive Director, HCG Ranchi. Mr. Abid, Director, Manipal Hospital, Ranchi. Mr. Vishwajit, Director, Medanta, Ranchi. And I would request Dr. Satish Sharma to just explain what this magazine is all about.
So, good morning. आप सभी को thank you for showing up in such a huge number in a Sunday morning. It's such a gloomy morning. It has been raining and people have come. So when I moved to Ranchi, मुझे ऐसा लगा कि we need a foundation, we need something which can inspire people and the stories. उससे अच्छा क्या होगा, stories से अच्छा कोई inspiration नहीं होता है. And we have been seeing stories, बहुत सारे survivors, बहुत सारे जो लोग हैं जो कैंसर के को strengthen करते हैं, वो हमारे बीच में ही होते हैं, but we never know. Like अगर 3 दिन पहले की बात करें, जब ये मैगजीन के पहले मैं ओपीडी कंसल्ट कर रहा था, तो आपको विश्वास नहीं होगा कि एक पेशेंट हमारे पास आया, बोला कि सर आपने आपका ये नाम सुना है. तो मैंने कहा कि ठीक है बताइए. कहते आपके यहाँ कीमो पोर्ट फ्लश कर सकते हैं क्या? मतलब कीमो पोर्ट फ्लश करने की अवेलेबिलिटी है. मतलब हम महीने में सप्ताह में 10 कीमो पोर्ट करते होंगे और कीमो पोर्ट फ्लश करने जैसी बेसिक चीज़ों को वो पूछ रहे थे. तो इतना मतलब सब कुछ होते हुए वी आर डूइंग टारगेट इम्यूनोस एवरीथिंग वी आर डूइंग. एंड उसके बाद भी अगर अभी भी हमें लगता है कि बड़ा गैप अभी भी बचा हुआ है. लाइक आई विल रिक्वेस्ट मिस्टर आबिद टू प्लीज ज्वाइन. सो मुझे लगता है कि उसके बाद भी एक बड़ा गैप हमारे बीच में है. एंड अ लॉट ऑफ टाइम हम ऐसा देखते हैं कि लोग सारी फैसिलिटी होते हुए भी दे हैव टू ट्रैवल बिकॉज दे डोंट नो. एंड इट इज़ ऑल्सो ऑनर कि जो अच्छा काम कर रहा है द पर्सन शुड बी अप्रिशिएटेड, तभी वो अच्छा काम कंटिन्यू कर सकते हैं. एंड पीपल विल शुड नो कि व्हाट द गुड वर्क दे हैव बीन डूइंग. सो इन दिस फाउंडेशन, जो हमारा फाउंडेशन है, व्हाट वी ट्राई टू हेल्प कि कैंसर का ट्रीटमेंट सब करते हैं, बट आई एम प्राउडली सेइंग दैट इन लास्ट 1 year वी कुड रिहैबिलिटेट अराउंड 25 of our patient in different works. हम बात करते हैं और उनको कहीं ना कहीं एम्प्लॉय करते हैं. बहुत बार क्या होता है, जो CSR होता है, बहुत बार हम रिक्वेस्ट करते हैं, बहुत लोग पैसा लेके नहीं आते. somebody traveling from दुमका, वो 5,000 रुपये लेके आया, तो हम लोग रिक्वेस्ट करते अपने फेलो डॉक्टर से कि ये प्रॉब्लम है, उसका कंसल्टेशन छोड़ देना. तो एज गुड एज स्मॉल थिंग. बहुत बार ब्लड नहीं होता तो वी अरेंज वॉलंटियर्स फॉर देम. अब कोई कोडरमा से आ रहा है तो कहाँ से ब्लड के बिना कीमो रुक जाएगा, कीमो के बिना आयुष्मान रुक जाएगा, सब कुछ कैंसिल हो जाएगा. तो दिस इज़ द बेसिक वर्क विच वी डू. So this is the light. थोड़ा बंद कर दो. So people ask me कि why you are आपने ये क्यों चुना पलाश की उम्मीद. तो I will tell you कि पलाश is a national state flower of Jharkhand and तेजिंदर मैम थी, she told this a state flower of Himachal Pradesh also. So we are so पलाश is a flower जो बचपन से हम लोग सब देखते हुए बड़े हुए हैं. And it is in almost all parts of झारखंड में. किसी भी आप गांव में रहिए, शहर में रहिए, पलाश तो आपको होगा ही होगा. एंड द ब्राइटनेस विथ विच आप जब भी आता है वो एक स्प्रिंग की तरह आता है ना. और ये एक उम्मीद हम करते हैं कि हम शायद आज से 5 साल 10 साल के बाद वी बिकम सच स्टेट इन झारखंड स्टेट की जहाँ पे लोग बाहर से भी, हमारे पास पेशेंट्स आते हैं उड़ीसा से आते हैं, हमारे पास ये होता है, बट स्टिल हमारे लोग तो बाहर जा रहे हैं. तो दिस इज़ द उम्मीद कि वी कैन क्रिएट अ इंफ्रास्ट्रक्चर, वी कैन क्रिएट अ कॉन्फिडेंस इन आवर पेशेंट्स कि उनको बाहर ना जाना पड़े. मुझे याद है कि जब मैं छोटा था तो मेरे आसपास, मैं रामगढ़ से हूँ, बगल के डिस्ट्रिक्ट से, तो लोग एक टाइम पे ऐसा था कि सर दर्द, खांसी, सर्दी, बुखार के लिए भी लोग सोचते कि एक बार बाहर दिखा लेंगे. बट जैसे स्टेंटिंग थी, स्टेंटिंग हमें लगता है कि अब शायद ही कोई बाहर जाता होगा कार्डियक स्टेंटिंग के लिए. सो कैन बी क्रिएट अ सच अ सिस्टम कि लोग को कैंसर में भी इतना कॉन्फिडेंस आ जाए कि दे कैन चूज दिस स्टेट, अपनी मर्जी से चुने. कुछ आयुष्मान पेशेंट है वो जा नहीं सकते, उनकी मजबूरी है, बट बहुत लोग जो जिसके पास ऑप्शन होता है वो उनको लगता है कि हम बाहर जाके दिखाएं, बिकॉज कॉन्फिडेंस नहीं है. तो यही उम्मीद है कि वी क्रिएट अ इकोसिस्टम, वी क्रिएट अ इंफ्रास्ट्रक्चर, वी क्रिएट अ सेट ऑफ डॉक्टर्स जहाँ पे वो इतने कॉन्फिडेंट हो कि जो ट्रीटमेंट हमारा रांची में होगा वो कहीं और भी होगा. नो, हमारे पास बहुत सारे पेशेंट्स हैं. मैं सर से बात कर रहा था कि हमने बहुत बार कीमो लिखा और उनके बच्चे जो यूएस में रहते, दे सेंड इट देयर. तो बोले सर वहाँ भी यही बता रहे. तो बोले यही होगा तो फिर बताएंगे क्या, नया क्या बताएंगे आपको. तो दिस इज़ द उम्मीद. तो इसमें हमने क्या किया कि वी हैव इंक्लूडेड पीपल who have strengthened the cancer services in Jharkhand. We have survivors जिन्होंने आउट परफॉर्म किया है, जिन्होंने अवेयरनेस के लिए काम किया है. एंड दिस इज़ आवर मोटो कि हम वैसे लोगों को स्ट्रेंथन करें और वैसे इकोसिस्टम को बनाएं जिससे हम ज़्यादा से ज़्यादा पेशेंट को रिटेन कर सके. एंड वी बिकम ए नेम इन कैंसर केयर. थैंक यू. सो दिस इज So we start with Mr. Arun Mishra. I think सर हैं, निकल गए लगता है. तो इनके फैमिली में लोगों को एक को कैंसर होता है और वो डर जाते हैं. इनके फैमिली में 3 लोगों को कैंसर हो गया, फैमिलियल BRCA पॉजिटिव डिजीज. But then 7 years on, he is an entrepreneur, he is an author, he has written book, Thank You Cancer. कैंसर ने हमें कितना सिखाया. तो he has written a book on Thank You Cancer. ये मुकेश पांडे जी, आई डोंट नो वेदर ही इज हियर और नॉट, बट मुकेश पांडे जी को हमने देखा, आई फर्स्ट से मैंने पहली बार देखा था बिलरुबिन 20 के आसपास था इनका, और ही गॉट ए वेरी रेयर लिम्फोमा, और उसके बाद हमने ट्रीट किया. आफ्टर दैट जब ये ठीक हो गए हैं, ही हैज़ क्रिएटेड 4000 वॉल्टियर्स का ग्रुप बनाए हैं जिसपे ही इज़ गोइंग, ही इज़ हेल्पिंग पीपल इन सदर हॉस्पिटल. कहीं भी कोई कैंसर का स्ट्रेस कॉल आता है, ही डज इट. तो इसमें मेंशन नहीं है, पर जो सबसे इम्पॉर्टेंट आदमी है यहाँ पे जो कैंसर केयर लेके आया है, सैयद अंसारी अंकल. आई थिंक व्हेन यू ओपन द मैगजीन, पहला चैप्टर ही हमने इनका डाला है कि द पर्सन हु कुड थिंक बियॉन्ड टाइम. अपने समय से पहले उन्होंने सोचा और फर्स्ट रेडिएशन मशीन ईस्टर्न इंडिया में इनके से हुआ IGRT लेके आए. एंड आज भी जो इनके मार्गदर्शन में द वे ही ब्रॉड कैंसर केयर टू झारखंड, उसके बाद आप देखोगे तो मल्टीपल हॉस्पिटल्स हैव कम अप एंड वी ऑल, ही इज ऑलवेज गार्जियन टू अस, गाइडिंग अस, टेलिंग अस, एंड विथ ऑल बिजी शेड्यूल ही विल फाइंड टाइम फॉर ऑल आवर सेशन. थैंक यू अंकल. तो वी विल गो विथ अ लॉन्च. Advani sir, you want to add something?
I think this is a most important part of the cancer treatment. Cancer is treated by the medical oncologist, surgical oncologist, radiation oncologist, and of course the pathologists play a very important role. But what the patient needs is the support care, and support is the care which he gets from what we nowadays call caregiver. And they form a very important cohesive group. They encourage each other, and that's how the people can really go through the treatment also very well. So I think integration in the cancer treatment of the so-called paramedical support group has become a very important part of the organization. Thank you.
थैंक यू डॉक्टर शर्मा आई थिंक आपने बहुत अच्छी बात कही है कि आई जस्ट टेक 1 or 2 लाइन्स फ्रॉम हिज वॉट एवर ही सेड कि ट्रीटमेंट सब जगह होता है एंड हम लोगों का सबका विश यही होता है पेशेंट एंड फैमिली का अगर हमारे घर के आसपास इलाज हो जाए तो सबसे अच्छा है एंड आई अंडरस्टैंड और मैं ये कहना चाहता हूँ कि विथ फुल रेस्पॉन्सिबिलिटी देयर आर मैनी सेंटर्स इन द कंट्री where or whatever best can be done in Mumbai, Delhi, Adyar or elsewhere probably can be replicated. So most of the time people should not be, they can seek second opinion, many patients do because failure is also common in this kind of disease. But they should be staying close to this thing, hometown, state, because that gives lot of confidence and other opportunity and other sahuliyat. Thank you very much.
I will request Ajit Kushwaha sir.
Thank you, everyone. Thanks, Dr. Satish, for the great book launch. And with this, we'll move further for the scientific sessions. We'll proceed with the further scientific sessions. Thanks to all the chairpersons. So we proceed with further scientific sessions, and for this, moving forward, I would like to invite Professor Dr. Atul Sharma, Chairman Medical Oncology, Max Hospital, Saket, Delhi, for his talk on immunotherapy in developing countries, impact in clinical practice.
All right, good afternoon, and thank you, Dr. Pradeep Sharma, for this invitation. So what I'm going to do is that all right, sorry for this thing, fiasco. So what I'm going to do is that probably I don't know what time, how session is it running late or not. So basically I'm going to speak briefly about immunotherapy in developing countries and what are the implications in our routine clinical practice. So why does we need to know more about the immunotherapy and its application and utility in our patient? Because I think each year, whatever the data, last data we have, about 20 million new cancer cases were detected. Close to 10 million cancer-related deaths occurred. And we have a distinct projection in next 20-25 years that each year there will be 35 million new cancer cases which will be detected. The problem is that the largest proportion of these new cancer cases is going to be developing to happen in the lower income settings, and unfortunately India is still being considered as a low middle income group or developing nation. There are clinical implications of immune checkpoint inhibitors, which we traditionally call immunotherapy, on diagnostic, delivery capacity, and also the affordability. Again, why does this matter? Because with the use of immuno-oncology drug, there is a shift in the cancer treatment. We've grown up using cytotoxic chemotherapy, and now we have learned how to modulate or immunomodulate the tumor cells and use that to our advantage. After China and US, India, China, US both are developed nations. India is still developing. India is among the most common country with the most common or high incidence of the cancer incidence. Another problem with the increasing cancer detection rates is that the 70, or that means 2/3 or more of these global cancer that they occur in the lower middle income countries. And we have another problem that many of these patients present in the late stage with the limited access to the treatment. We have high incidence of the GI, head and neck, and cervical and breast cancer. And immunotherapy is available in the country. It is transformative, but this is not the unequitable. What I mean to say is that whatever the access the developed nation have, we don't have similar access. Why are patients or they are not able to receive the way we want them to receive? Because they are potential, I'll come to that, what are these things, reason for not able to receive. But the theoretical potential advantage which Dr. Advani was also mentioning, we do get durable responses, we do get long-term and less cumulative toxicity. The current landscape of immunotherapy I'm not going to discuss. This has been briefly touched yesterday and also this morning by Dr. Advani. I'm not going into this thing. So what my job is that why are patients not able to receive the way we want them to receive? Because there are certain barriers to implementation in developing nation, including India. What are these barriers? The most important becomes the high cost of the immunotherapy. So that is one of the most important or limiting factor, I would say. Still in our country, about 45, it used to be about 10 years ago, it used to be 2/3 of the out-of-pocket expenses by Indian subjects, both in urban and the rural area. It has come down close to 50%, but still 50% of the expenses in the treatment is being borne by the patient. It may be because of the travel cost, because of the stay and other thing, Still, insurance coverage, more and more people or population is asking or taking insurance coverage, but still that is a limiting factor. And we don't have the national reimbursement policies. The few centers, few employees after retirement, they don't get the reimbursement. Few employees or service they do give. Another problem, apart from the economic barrier, is the infrastructure barrier. We don't have the adequate, this thing, I'm not saying that we don't, but we still need more, let me put it that way, the pathology and molecular testing facilities. Many good centers, they don't have in-house facility for testing of the PDL1, MSI or TMB. The sample is being sent outside. And of course, ICU support and so many this thing. Most of the clinical trials where the immuno-oncology drugs have been approved, probably representation from developing nations or India in particular was low. Whether we have a tumor, different biology, we don't know. Of course, as again, like we were discussing about urban, rural, or maybe the develops, there are few states which have the more facilities, few states they don't have equal facility. And of course, it goes without saying that we have the trained shortage of the trained oncologists, whether this is medical, radiation, or surgical oncologists, and lack of multidisciplinary team in many centers. Of course, we need probably, so also we need to learn about once we start someone on the immuno-oncology drug, what are the criteria that we should be stopping? Shall we continue until the disease progression or until the intolerance, or we can safely stop after 1 year or 2 years? Remember trastuzumab when it was introduced for the metastatic breast cancer, it used to be continued indefinitely. For the HER2 positive adjuvant setting also, there was a time limit, but now we know that even 6 months of the treatment may be effective for HER2 positive breast cancer tumor. So this also gives a unique opportunity for our country because of the deficiency or routine availability of immuno-oncology drug, and we can take that to our advantage. How can we do that? We can innovate and we can adapt new guidelines. The reason why I'm saying is that because this is a unique opportunity. We have the facility, lot of scientific talent is available, and recently, last year or so, we have the biosimilar of one of the immuno-oncology drug which is available in the country. By using local manufacturing this commitment from the MNC and this thing, possibly will be able to reduce the tumor, reduce the cost. We may use, how can this opportunity to our advantage, dose and duration de-escalation trial, and there are successful trials conducted in the country by various groups. Instead of the weight-based dosing, we can use a flat dosing and biosimilar biomarker-light approaches. All these clinical trials where the immuno-oncology drugs were approved have been conducted in a particular kind of the patient population, fit patient population, generally probably otherwise without comorbidity and this thing. Instead of that, we can use the pragmatic trial design. And what are these pragmatic trial design? Basically, we can do these kind of things in the real life patients which we see in the clinical practice. That means real world evidence. Of course, we can have the public-private partnership. Government can negotiate with the MNCs because still as of now, the bulk of the immuno-oncology drugs are being imported into the country. Bulk purchase give a unique advantage to the center which is purchasing because TMS does it, AIMS does it, and I'm sure many other centers, railways, defense sector and this thing. If they purchase in the thing, it gives a lot of negotiation or negotiating power to this thing. Pharma industry, on their side, they are helping the patient. They have lot of the patient access assistance program. We call it PAP. And with that number of patients who are able to use immuno-oncology drug is this thing. Of course, involvement of the NGO. I can just skip, and I can skip this also. I can come to the few of the studies. So India is leading from the front with regard to the adaptations. So low dose, this thing, immunotherapy. De-escalation trial. The first such study came from Tata Memorial Center, Mumbai, and they use low-dose nivolumab, and that they have shown that along with if you use oral metonymic therapy, triple metonymic chemotherapy, low-dose immunotherapy improves the survival. And it does give, so that time it used to be much more expensive. Now probably even this may be less than 200,000 compared to the original molecule, with also is available in 1 million to 1.5 million. So they compare, so these are other few examples of this thing, the same example with triple metonymic therapy with 7 months, with triple metonymic therapy plus low dose nivolumab, 10 months of the survival advantage. These are some other examples of the so this real world low and middle immunotherapy in the low and middle income countries, showing that if you use a select your population with the PD-L1 population of 50% and above, there is about 2.5 to 3-fold increase in the survival. This is the recent study published in the Annals of Oncology from AIMS Delhi, one of my former colleagues. Low dose pembro in addition to the neoadjuvant anthracycline triple negative breast cancer. Very simple trial design. They just use 3 doses of pembrolizumab at an interval of 6 weeks, 50 milligram, and they have shown that there is an increase in the pathological complete response rate compared to the chemotherapy alone. This is probably one of the first study in the breast cancer. Again, we have the recent publication from the Tata Memorial Center where they use ultra low dose immunotherapy in relapsed refractory solid tumors, and they have shown that the patients, so don't go into the incremental value of the survival advantage. The primary endpoint was the OS, but you see the relative advantage. So as such, it just gave 1 month, but then you have an option. Physician choice of the chemotherapy versus immunotherapy, the significant improvement in the overall survival. So these are the few things which should be doing for low and middle income countries. We should prioritize which are the indications where the immunotherapy should be applicable or should be useful. We choose 2 or 3 indications where we definitely have high benefit, and these are the common cancer in the otherwise our population. We build a minimal biomarker pathway where we should be using these molecules. We use visit reducing schedules. Instead of every 2 weeks, we can call every 4 weeks. Instead of 3 weeks, we can call patient every 6 weeks, and so on. The future directions, low middle income countries specific biomarker where we can use them. We should be using maybe that short course immunotherapy trials should be conducted. We can combine with a metonymic oral chemotherapy and so on. So just to take home, immunotherapy is transformative, but as of now, it's not automatic equitable. We need to do that. Developing nations, low middle income countries require contextualized oncology, not copied from the Western guidelines. We should be smart enough to select our protocol, and policy reform from the government and other side is also needed. And this is an opportunity. We can innovate leaner and more rational use of the immuno-oncology drugs. I'll stop it here, and thank you very much for the patient hearing.
Thank you, sir. Thank you, sir. Such an excellent talk. Just one question, sir. What is your take on biosimilars?
So I would say that the biosimilar are here to stay, number 1. Number 2, as I understand, as of now, there is only one molecule, one company. So they have spent close to 10 years, and that has gone under clinical trial. It has been approved by the regulatory bodies and also the government in India. So personally, I don't think that we should be doubting that.
So being like reaching this treatment, these are excellent modality recently, like whatever the humanity could have, this immunotherapies. And but reaching these therapies to the real patients, because we deal with the real patients, and if you will see, Ranchi have millions of, the Jharkhand have millions, and India has millions of cancer patients. So I personally feel that biosimilar and gradually including these biosimilars or even like real molecules into the Ayushman will really make a huge change for that kind of treatment like we are having in developing country, and we are doing that. So biosimilar inclusiveness is the main solution, and Ayushman inclusion is the main solution, I personally feel, sir. But things are great, and the kind of information I got from your lecture, it's awesome, sir.
Absolutely in agreement, complete agreement. The only other point, biosimilar is well taken. I have no doubt about using these molecules. Other thing that maybe the Indian pharma industry should be investing more in the research and development, which is something which is probably not happening
True,
to the
sir.
extent.
So that should not be stopped, but like reaching to the real masses is the major challenge always we face, and especially with the new kind of treatments. And immunotherapy is really changing the way like cancer was treated so
It's
far.
game changer, I would say, in
Yes,
many
sir. Yes,
cancer.
sir.
All right, thank you very much.
Thank you, sir.
Thank you very much.
I would request Dr. Deepak Agarwal, sir, to join as a chairperson for chairing the session.
For the next session, I would like to invite Dr. Tejinder Kataria. She will deliver a lecture on Madam is a chairperson and radiation oncologist at Medanta, Gurugram. And welcome, madam. And would like to hear about your thoughts on the role of immunotherapy in radiation oncology.
Good afternoon, respected chairpersons and the audience. Thank you so much for being here, and I'd like to thank Dr. Satish Sharma for inviting me to this scientific bonanza. So I'll be speaking about RAISE that heal, that is the radiation oncology part, and its contribution to cancer care in the era of immuno-oncology. So we'll just briefly go through the introduction, and then what are the effects of radiation on cancer cells? What is the interaction of radiation with immunotherapy? What are the unanswered questions? Where does radiation stand in the era of precision medicine? And to conclude then thereafter. So radiation goes back to 1895, when it was discovered by Wilhelm Röntgen at Würzburg in Germany. And for the first time, it was used in 1897 in Sweden by Dr. Thor Schneider. And it's progressed through 1920s and 1950s when the megavoltage was introduced, to now conformal radiation with the computational algorithms, to stereotactic radiosurgery and stereotactic body radiation. Simultaneously, the immunotherapy has evolved from late 1800, when it was used by kill bacterial vaccine formation to raise the temperature of the body to kill cancer, to the exotic drugs and the monoclonal antibodies and immunotherapy, which we've been witnessing over the last 2 days. So what is the effect of radiation on the cancer cell? So radiation kills the tumor cells directly by breaking the double-strand DNA strands, which is called the double-strand DSA, and also by the indirect mechanism by acting on 70% of the water molecules which are there in the body, by breaking down the water molecule and releasing the nascent oxygen or the hydroxyl ion, which then breaks the double-strand DNA. And these strand breaks, if not repaired or potentially damaged, unrepaired would then lead to the cancer cell death directly. But the tumor is not acting or staying in isolation. It's surrounded by the tumor microenvironment, which is inclusive of the diverse immune cells, cancer-associated fibroblasts, endothelial cells, new vascular structures, and the extracellular matrix. And this normal tumor microenvironment can constrain the tumor outgrowth through the suppressive functions of immune cells, fibroblasts, and the extracellular matrix. But cancer evades these through the influence of cells to become tumor-promoting, resulting in increased proliferation, invasion, and intravasion at the primary site, and thereby disseminating through the lymphatics, the vascular cells, and through the vascular channels to distant sites. And the regulation of the metastatic cell's fate in different environments can be considered a battle between the different types of the immune cells, as depicted in the center of the figure, and the host environment, the neutrophils, and the circulating tumor cells. The natural killer cells are trying to knock the tumor out, the T cells are trying to contain the tumor, but the platelets are engaged by the tumor to increase the intravasion and the extravasation into the host areas, that is the liver, bone marrow, lungs, brain, and other sites. So there are layers of complexity in targeting for the cure of cancer, which are patient intrinsic features elaborated through the demographics, the environmental factors, or the host factors, the cancer intrinsic cell mechanisms, then the properties of the tumor microenvironment, and then the therapeutic interventions. Of these, we know mainly surgery, medical oncology, but then immunotherapy and radiation synergy is what we are going to discuss in the next 10 minutes. So what radiation does is, besides killing the tumors by directly breaking the double-strand DNA strands, it also raises the immune-mediated action on the cells. And what it does is that it produces the DNA damage-mediated immune response, or the damage-mediated molecular pathways, which then cause the downstream signaling in the intracellular domain into the cytosol and the nucleus to further set off the cytokine cascade. And also these DAMPs are picked up by the dendritic cells and taken through the lymphatics or the reticuloendothelial system to the lymph nodes. Besides this, the second thing which is happening is that the vascular endothelial damage occurs when radiation is given, because the tumor cell or the tumor environment vasculature lacks oxygen, is hypoxic, they are ill-formed, and single-layer cell thick, and they are amenable to high doses of radiation for destruction. So there's a twofold change which is happening here. One is the endothelial vascular damage, and you can see with the high dose on the left side, without radiation, there's a high vascularity picked up by the red color, but post-radiation that completely disappears, and there is immune activation. And as we just now learned that the dendritic cells pick up these broken down tumor cells and through the cytokine pathway rush through the reticuloendothelial system of the body, which is a massive network of lymphatics and maximally situated within the skin, thereby to the lymph nodes, to the liver, the spleen, and the bone marrow. And to aid that, we have something known as the stereotactic radiation, which is delivered very accurately and precisely to any part of the body through a system called as the stereotactic body radiation and stereotactic radiosurgery. So when a tumor is removed completely by surgery, is minimized by chemotherapy, but then still comes back as an oligoprogression or as an oligorecurrence, radiation is brought in and it tries to kill out and helps in eliminating these recurrences. So what this technique does is it initiates the antigen presentation by promoting the release of tumor-associated antigens and MHC1 cells, the complex that induces the immunogenic cell death in the tumor cells. And the anti-tumor immunity initiation occurs in the tumor-draining lymph nodes, where the immune cells develop the progenitor cells after binding to the antigens, and then they engage to differentiate into tumor-associated antigen-specific cytotoxic T cells, which is what we learned in the morning lectures are the killer cells for the tumor, wherever they are going to then travel on. And the synergy between the stereotactic body radiation and the immune checkpoint blockade happens because the stereotactic body radiation transforms the treatment-naive tumor microenvironment into hot tumor by producing the immune-activating molecules and immune-related surface molecules. So this synergy of stereotactic body radiation and the immune checkpoint blockade promotes infiltration of the immune cells via upregulation of adhesion molecules or the chemokines. And it contributes to the adaptive immune resistance via the interferon, which can then upregulate the programmed death ligand and the VISTA expression on the tumor cells, thereby aiding the immunotherapy to engage further tumor cell kill. So this is let's understand the interaction of radiation. What happens is that radiation has the ability to convert the irradiated tumor into an in situ vaccine. And then immunotherapy exerts its effect by promoting the immune response inherent to the host, and there is a synergy which is produced. Besides this, the direct cell kill, the tumor cell broken, damaged proteins can also lead to an abscopal effect away from the tumor site through the circulating T cells. And here we see that the radiation induces the DNA damage, but that the immunotherapy is engaged through the breaking of the PD-L1 and the PD-1 shake hand that is blocking the tumor cells being killed by either the immunotherapy or the radiation. And this synergy then helps us overcome the immune inhibition which is mounted by the tumor cells. And there are drugs which are involved, atezolizumab, evolizumab, durvalumab, which are used at the PD-L1 site, and the nivolumab, pembrolizumab, and its associates on the programmed death protein receptor site. So what are the unanswered questions here? What is the best type of immunotherapy that can work with radiation? What is the best sequence or schedule? Will it lead to healthy tissue toxicity? With ultimate conformal radiation, we are able to reduce the normal tissue toxicity because that can be taken away by the computer programming. But the immune system cannot be isolated. What are the biomarkers for patient selection? How to overcome the tumor resistance? So the best immunotherapy for radiation is still evolving, and we can use it with chemotherapy, with radiation, with chemoradiation, and immunotherapy. So these are the drugs which are there. I don't need to speak about them because we have a lot of medical oncologists and immunotherapy experts sitting in the audience. And at all points, you can see that the radiation works in the different pathways at PD-L1, PD-1, CTLA4, GM-CSF, and TGF-beta pathways, and can assist in synergizing and potentiating the effect of immunotherapy in increasing the tumor control. So what is the basis of combining radiation with immunotherapy? So there's a spatial cooperation, there's a biological cooperation, there can be a temporal modulation where you give either immunotherapy earlier, concurrently, or sequentially, or you can increase the cytotoxic enhancement by giving cytotoxic treatment, then giving radiation, and then giving the immune modulators. So best sequence or schedule is evolving. These are 3 studies which I have elucidated here. NRG Oncology GY017 was a dose-finding study for the atezolizumab for cervical cancer, where they just looked at the expression and the clonal expansion of the T cells, and it was just the phase 1 study to establish the efficacy. It's been proven to be right, it's safe, and there was a clonal expansion of the T cells more in the patients who were exposed to atezolizumab with radiation versus only radiation. In the key chain, chemoradiation plus pembrolizumab versus radiation alone for head and neck cancers was given. It was again a phase 2 study, and it showed that the patients who received chemoradiation along with pembro, they had a 40% better response in local control versus patients who received only chemoradiation. And Pacific, the data is very mature, phase 3 trial, where durvalumab post-chemoradiation for stage 3 and beyond non-small cell lung cancer has proven its benefit when given in the adjuvant setting. So radiation immunogenicity, because of the tumor microenvironment modulation, can be engaged at a very low dose of 0.5 gray per day given in just 4 days. That is 2 gray dose given in 2 days and then given with immunotherapy. Or there can be immunomodulatory radiation when it's given in hypofractionation of 6 to 8 gray over 3 to 5 days. Or it can be immunoablative when a very high single dose of 30 or 34 gray is given, and this is engaged in patients with hepatocellular carcinoma or less than 3 metastases, less than 2 centimeters in size in the lung cancer. There can be hybrid schedules, or where you give a single fraction to the large metastatic site and low dose to the smaller areas where there is oligoprogression. And there can be multi-fraction, that's more than one fraction, when you deliver 3 to 5 fractions of radiation, and then either preceding that you give the immunotherapy and then succeeding that again. So there has to be a gap of 3 to 5 days before you give the radiation in such a situation, so that you do not increase the side effects of the immunotherapy. So the factors associated with the efficacy of radioimmunotherapy are multifactorial, and then it can be divided into what expressions of the chemokines and the receptors are there that you can engage the radiation there. Sorry, it's not moving. So optimal sequence, we've already discussed. Now in the era of precision medicine, these are 2 studies which showed that in the Keynote 001, patients who have had previous radiation and then were exposed to pembrolizumab in non-small cell lung carcinoma, there was doubling of overall survival. And when the patients were given pembrolizumab with stereotactic body radiation in advanced non-small cell lung cancer, there was doubling of overall response rate from 18 to 36%. So there is a synergy here, which we have deployed in the clinic. This is an 80-year-old gentleman who had coronary artery disease, was not a fit patient for concurrent chemoradiation, T3N3 disease with a centrally located tumor. We gave him SBRT and then followed by pembrolizumab in 2019. The gentleman was free of lung cancer at the time of his demise in 2023. A very good result with a good quality of life, but a good choice which had to be discussed with the medical oncologist and given to the patient. Coming to stereotactic arc body radiation or the stereotactic body radiation with nivolumab versus stereotactic body radiation alone in T1 to T3 non-small cell node-negative lung cancers has shown there is a 4 years event-free survival benefit of 24%. That means with alone stereotactic body radiation, we have a 53% event-free survival versus 77% when nivolumab is added. So immunotherapy and radiation are working together for increasing the event-free survival here. This is another gentleman with a T4 disease infiltrating into the ribs here, and the 8 centimeters in tumor. We gave 60 grain 8 fractions followed by pembrolizumab 18 months. And the patient did develop a little bit of asymptomatic pneumonitis, but no respiratory distress, and is disease-free at 18 months. Now coming to CNS very briefly, normally despite giving immunotherapy, despite giving chemotherapy, surgery, and radiation in the extracranial domain, we do see 25 to 30% of patients relapsing in the brain. That is because the blood-brain barrier does not allow these molecules to penetrate. So CNS is immunologically distinct rather than privileged. But when we add stereotactic radiosurgery, then the 5-year controls along with immunotherapy increased to 81%, which is a very remarkable change from when we gave whole brain radiation 10 and 15 years ago. And we can see the waterfall plot here for the lung cancer that the addition of immunotherapy with stereotactic body radiation has increased the local control to 100% with the SABR, and in the disease control to 97% versus 84%. So what else is brewing here? Just very briefly to bring you in the era of precision medicine, that we are looking at smart radiation, which is known as the spatially fractionated high-dose radiation for large tumors, where you can give discrete high-dose spots within a lattice grid to the larger tumors and smaller dose over the next few days, and then engage the patients with the chemotherapy. So to conclude, in the present era of immuno-oncology, radiation has more and more important role to play. Radiation was and is a cure for various cancers. In conjugation with immunotherapy, radiation is doing wonders if given a longer and a better quality of life to metastatic patients as well as to patients who are not amenable for other treatments. Newer technologies enable better radiation delivery with fewer side effects, and newer avenues with newer indications, non-invasive treatment is evolving. And what the principle for radiation is to minimize the normal tissue damage and increase the tumor control. So we segregate the therapeutic ratio and try to reduce the side effects in the patient. And there are technological innovations, biological and targeting strategies, and treatment delivery and optimization of the schedules of treatment. So we can cure the cancer because there is a can in the cancer. With that, I'd like to thank you so much.
Thank you, ma'am. You have beautifully shown that how the radiobiology of radiation and mechanism of immunotherapy can work together wonderfully in clinical outcome. So any questions from the house?
I have a question. So
other ATC. And what if we are saying about the neoadjuvant setting in HER2 breast cancer, so there are some indication that if tumor is more than 2 centimeter or patient presents with high risk disease burden and there is high tumor breast ratio, then we can add approach is neoadjuvant setting patient with high risk factor like high grade of tumor, HER2 positive and TNBC, then we should approach for neoadjuvant setting. And almost all of the patients more than 2 centimeter with node positive, the approach is dual targetable, that is trastuzumab and pertuzumab. And in subsequent slide, we will try to relate the role of pertuzumab in this setting. If we see the new SPR on TRIFINA trial, addition of pertuzumab had greater PCR rate in comparison only chemotherapy plus trastuzumab. In some real world data, we have seen the retrospective data, though the number is very much less, like 10 to 20 number of patients, still there is PCR rate of almost 60 to 70% or crossing to more than 70% and coming even up to 83% also. And this is the data published in recent ASCO 2026, where the pathological complete response is seen of almost 64% of patient if the dual IV formulation versus subcutaneous formulation has been administered. And other real world data like Ananya Care and post-marketing surveillance, they have shown the PCR rate on addition of dual HER2 is almost 64 to 75%. Can we omit the standard of care for this neoadjuvant setting is TCHP? Can we omit the carboplatin or can we replace the docetaxel carboplatin arm in the TCHP arm with the nab-paclitaxel arm? This trial of NeoCarb or Helen 006 says the answer. In NeoCarb trial, if we trastuzumab and omit the carboplatin arm, the PCR rate is almost similar, like 64% versus 65.9%, and which is non-inferior trial seen in this case. Even in the Helen 1, the PCR rate increasing if we omit the docetaxel and carboplatin and replace with the nab-paclitaxel arm, then PCR rate increases to up to 70 to 80%. The increase of this PCR rate can be elaborated by that target more frequent dose of nab-paclitaxel, and also the mechanism of action of nab-paclitaxel is quite much different from the other like docetaxel or carboplatin arm. The toxicity is quite manageable, and the lesser toxicity has been seen in the nab-paclitaxel arm also. In adjuvant landscape, this is the landmark trial of affinity. We all know about this affinity trial has shown some IDFS benefit even in the final result up to more than 8 years, 11.3 years updated results shows that there is this IDFS benefit is translated into positive OS benefit, which is delta of 1.8%, and more delta are seen in the node positive patients, and the is approximately delta of 2.7%. So even node positive had some benefit with addition of this pertuzumab in this trial. So even our guideline also says that if there is neoadjuvant setting, then after histopathology report there is PCR, so we have to continue the trastuzumab and pertuzumab in the adjuvant settings also. And this recent updated guideline, what they have said that more than 2 centimeter we have to add pertuzumab, and node positive definitely we have to add pertuzumab in the neoadjuvant setting. So if there is not PCR, like patient received neoadjuvant chemotherapy and after histopathology report residual disease is there, so there is increasing chance of recurrence, and that can be taken care of by addition of switching to TDM1. This Catherine trial shows that the switching of TDM1 in residual disease, but in residual disease post neoadjuvant setting there is IDFS benefit, and in the long follow-up data of 8.4 years which is almost 13.7% of IDFS benefit at 7 years with a hazard ratio of 0.54. Even the updated OS also showed presented in SABS 2023 had a 4.7% OS benefit at 7 years. So even in subgroup analysis, small residual tumor like node positive or less than 1 centimeter had some benefit. If we switch to TDM1 in the post neoadjuvant setting, then followed by residual is there, then we have to switch to 14 cycle of adrotrastuzumab. The NCCN guideline also supports this. And coming to metastatic setting, in first line setting, the Cleopatra shows that addition of pertuzumab with chemotherapy and trastuzumab backbone had there is OS benefit of approximately 17 months. This 17 months difference is quite much good in a metastatic setting of breast cancer. If the newer molecule like ADC like TDXT, which has some promising result showed in Destiny Breast 09, but the data is maturing, OS data is not much matured enough. And if we see the median PFS value is 14 months versus 26.9 months. So we are waiting for the data to mature. And if we see the subset analysis, the median PFS on the hormone positive plus that is triple positive subset analysis, patient receiving TDXD had a median PS of 38 months. So coming to, we will keep this 38 months in mind, and coming to Patina trial, which showed after in triple positive cancer like PR positive and HER2 positive, there is started with chemotherapy. If after 6 to 8 cycle there is stable disease or good response, then we are adding palbociclib and hormonal therapy. And we compared with the without palbociclib and had good median PFS of 44 months versus 29 months, which is better than the Destiny Breast 09, though the cross trial comparison is not fair. Coming to the role of tucatinib, which was seen in HER2CLIMB 05 and in metastatic breast cancer, and there showed that the switching to tucatinib as a maintenance therapy has a median PFS of 28 months, that is 12 months of difference, 12.9 months of difference in BICR review. Even in hormonal status, or both the hormone positive and the hormone negative arm had some benefit. If we see the brain metastasis patient, there is almost doubling of CNS PFS benefit, that is 8.4 months in patients receiving tucatinib versus 4.3 months the patient on placebo arm. In second line arm without CNS involvement in HER2 positive breast cancer, these three trials take that revolution, that is Emilia trial supported the role of TDM1, DB-based 09, which proved the role of second line TDXD after progression of pertuzumab therapy, and LabTak07 versus capecitabine proved the role of lapatinib and capecitabine. So patient with breast metastasis, we all know that eventually hormone positive in HER2 positive patients had a greater chances of brain metastasis in the long run, and almost more than 50% of patients will develop in the course of this disease, brain metastasis. So HER2CLIMB, this trial showed the role of tucatinib, and the patient receiving tucatinib, that even the brain metastasis patients which are receiving tucatinib had some good intracranial response of 47% versus the patient who are not receiving tucatinib, that is almost 20%. Even the OS, if we see the brain metastasis had 2 year, even in 1 year there are some good OS favoring the tucatinib arm, even with the patient of brain metastasis. The patient who are in active CNS metastasis, the CNS PFS is much more high, which replicate to OS benefit even in patients who are receiving the tucatinib. So that this tucatinib, they delay the process of new brain metastasis. For this, the gap is almost 11.1 month. So the next surgery or maybe radiation, the need of radiation is delayed by almost 1 year, and the patient does not receive any kind of treatment or directed therapy, or there is no need of local therapy almost 11 months if the patient is receiving tucatinib. So had some good intracranial activity, as it is a TKI, crosses the blood-brain barrier, and in third line almost the papers are phase 2, and the role is mostly for tucatinib, and even the patient's progression after TDXD, the tucatinib plays a role. So if we see the guideline in active brain metastasis, tucatinib is one of the choice for the brain metastasis patient in HER2 positive breast cancer, and even with active brain metastasis or asymptomatic brain metastasis, each patient is presented with brain metastasis, or in the long run, tucatinib is one of the choice for this. So other guideline like NCC also shows that we should prefer category 1 recommendation is tucatinib plus trastuzumab plus capecitabine, and the other recommendation is also like TKI is one of the recommendation. So we have tucatinib, pertuzumab and TDM1 in progression disease, or like patients present with brain metastasis, we can use tucatinib, and pertuzumab is one of the backbone from neoadjuvant setting, and also there is role for adjuvant setting in addition of pertuzumab, we get the benefit of OS and IDFS benefit. So what we can conclude that the use of HER2 agents are increasing, the newer molecule is coming, and we can judicial use of de-escalating therapy of chemotherapy can be done, but we keep in mind the patient profile also, and there is role of pertuzumab in the adjuvant setting also, and neoadjuvant and in metastatic setting we should start it with dual HER2 therapy with addition, and in brain metastasis tucatinib is one of the preferable drug we can use. And thank you all, and thank you for patient listening.
Thank you, Dr. Parag, for excellent presentation. Any question from our audience? What is your experience with TDX? What is your personal experience with TDXD?
Sir, still now I have just using one patient in TDXD, so I will wait, and it is ongoing. So we are routinely doing the guideline, what does they say, like echo or the pulmonary complication, what we are expected. We are doing CT scan of thorax every 6 weekly. So in my personal experience, till now I have not get any complications.
Okay, thank you.
Thank you.
How much is the endocrinopathy associated with this molecule? What is the endocrinopathies? The risk of hypothyroidism, the adrenal with this molecule, what is it? Overall? Yeah, tell me.
Mostly in immunotherapy, I used to say, I used to get hypothyroidism,
yeah.
And I only seen 1 or 2 patients with hyperthyroidism, and pulmonary complications are more I get. And in my personal experience, immunotherapy, one of my patient, I had to stop immunotherapy after 5 or 6 cycles.
Yes.
And one bad thing happened with one of my patients, that one patient expired due to pneumonitis.
Did you encounter any adrenal crisis also using this molecule?
Not yet, sir, but
yeah.
We suspect, but we got investigated, but that was adrenal crisis.
Okay, thank you very so much.
Thank you, sir.
Thank you. I'll request Atul Sharma sir to please come on stage for felicitation.
Thank you, sir.
I'll request Bharat Singh sir to please come. As we move to last segment, I'll request Dr. Riaz, who is a senior hematologist at Max Hospital, for the next talk. Thank you.
Good afternoon, everyone. So before we wind up, I think so I'm the last speaker. So coming to the topic, I have been given the topic of approach to optimal management of frontline multiple myeloma. This is the place where we work. This is Max Saket. The new building has come, and this is my topic. And so multiple myeloma is one of the most common blood cancers we see. This is one of those cancers where we diagnose clinically and then we confirm with the lab. Oncology has got the other way around. Most of the time, patients are symptomatic for fever, weight loss, some lymphadenopathy or tumor mass. When they get biopsied, when the biopsy results, the pathologists tell you, okay, this is cancer A, B, C, whatever. And then the oncologists come into play. That what treatment, staging, and prognosis has been decided. Multiple myeloma is just the other way around. Patient can present to physician with low hemoglobin, getting evaluated for low hemoglobin. Patient can present to a nephrologist for renal failure. Patient can present to orthopedician for bony fractures. And from that, the clinical suspicion is raised whether it is a myeloma, and when further evaluation is done, then you have the diagnosis of multiple myeloma. So multiple myeloma being first clinical diagnosis, combination of you see the diagnostic approach, then you confirm that is multiple myeloma or not. Multiple myeloma has come a long way from being say 5-year survival was 20 to 30% 10 years back to more than 70% of the patient are going to have 70% of the patient have 5-year survival. Multiple myeloma is another thing. It's a non-curable disease. You cannot cure it. The only thing what we can do is we can prolong the disease survival. We have bring the disease under control. Whatever we do, it is only the remission rates we are increasing. We are not curing it. Unlike other blood cancers, we are using the word cure. So this is the typical presentation. When we have an active myeloma, you treat the disease, it brings under control, patient is in remission. Over a period of time, it relapses again and again, and we give the second line, third line, and finally. So the whole idea of treating multiple myeloma is to bring the disease under control, prolong its survival, delay the first relapse as much as possible. Now also, we should not keep the best for the last. If you see the real world data, most of the patient will treat first line. From the second line, either they are transplant eligible or ineligible, you see the number of patients differing their treatment happens. So always go for the better line. If this graph shows that 20,000 patients in the first line, second line, even if they are transplant ineligible, only 9,500 patients are taking the second line of treatment. Now, development of treatment. So those were the days when we treated 10 years back with steroids and thalidomide. Now, newer drugs have come, that is IMiDs and proteasome inhibitors, but transplant has still remained, what it started in 1970 still remain the backbone. Transplant initially used to be the costliest, but with the advent of immunotherapies, that is CD38 monoclonal antibody, transplant remains still the cheapest therapy in multiple myeloma. So any patient who is less than 65 years of age, who is clinically fit, should undergo bone marrow transplant in multiple myeloma to prolong their survival and good quality of life. This is what I was saying 5 years back. 30% of the patient will be going for 5 years survival, but now almost 70% of the patient going for more than 5 to 10 years. Now, what actually you should treat? Now, the treatment can vary from doublet, triplet to quadruplet. What is this? Combination of 2 drugs to combination of 3 drugs to combination of 4 drugs. So once you have diagnosed multiple myeloma, you must differentiate between standard risk and a high risk. If your patient is clinically fit and they have the money, go for quadruplet. What is quadruplet? Combination of daratumab, that is CD anti-38, PI, IMiD and dexamethasone. The 4-drug regimen should be given, which we come in later, followed by transplant, followed by maintenance. This is the standard treatment given in the guidelines. And if it is ineligible, you can go for triplet. Use the immunotherapy in the first line, second line, if possible, if the patient is financially stable. Now, autologous stem cell transplant, once the patient has gone into remission, please proceed for transplant. Please encourage your patients to go for autologous. How do we do it? Once the patient is in remission, take the stem cells, use high-dose melphalan, and again reinfuse the stem cell. That gives at least 3 to 5 years of progression-free survival in any standard risk, and 3 years at least in high-risk patients. So autologous transplant in current era remains one of the cheapest therapy of, in cases of multiple myeloma, in contrast to other diseases where still the cost is an issue. Post-transplant, how do we do it? We do, once they have received, if they have achieved MRD negativity, you can directly go for maintenance. Otherwise, you can go for consolidation followed by maintenance. The idea is to keep the disease under control as long as possible. MRD, we are talking in all the diseases in the same way we are talking in multiple myeloma. MRD is minimal residual disease. So diagnosis is initially made on the number of plasma cells in the bone marrow. You are counting 100 cells and then you are saying 60-70% of plasma cells. When it is less than 5% or say 1 or 2%, you say morphological remission. But if you count 1 lakh cell and still you have got less than 5%, that is MRD negativity. So sustained MRD negativity, that is you are repeating a bone marrow plasma cells in a gap of 6 months to if you have got 2 MRD negativity, you can say you can stop the even maintenance therapy that we are the new thing where you no need to continue maintenance therapy. So MRD in a patient should be advocated as much as possible, and the use is you can stop therapy if you have got sustained MRD negativity. So going to the further, this is the Darzalex, which is the newer thing, daratumab, which is the drug of choice at present. This is the CD anti-38 molecule. If combined with bortezomib, lenalidomide and dexamethasone, it can give at least 70% chance of the operational cure. In India, we are seeing myeloma at a younger age, but most of the patients, those who are more than 60 years of age, if treated with quadruplet followed by transplant, 20 to 30% of patients may never relapse. It doesn't mean they are cured. What we say, it's an operational cure. Operational cure means patients may remain into remission for another 5 to 10 years with this quadruplet therapy, and in 20-30% of the cases. These are different trials which has elicited the benefit of Darzalex. In Maya trial, acyclone, Griffin, I won't go into too much detail. This is the way we give it, at least 4 cycles, 16 doses to be given in newly diagnosed transplant eligible or ineligible the daratumumab works. Now this is one trial which is I'm going to discuss. This is the Perseus trial. Perseus trial is subcutaneous daratumumab with bortezomib, lenalidomide and dexamethasone when compared with triplet therapy. If you see, if they have received 2 to 4 cycles, when they gone for transplant, post-transplant, reassess, and when they are MRD positive, go for dual maintenance, consolidation followed by dual maintenance, or you can go by single lenalidomide maintenance. So the whole idea, if you can see in patient receiving Dara VRD versus VRD, that is quadruplet versus triplet therapy, there was 58% reduction in risk of disease progression or death. So what do we mean by that? At least 50% of the patient will never relapse. The disease will remain under control for another 5 to 10 years. Now, median progression-free survival projected to be 17 years for transplant-eligible patient receiving Darzalex. So this is what the beauty is. If you treat the patient with 2 to 4 cycles of quadruplet, followed by transplant, followed by maintenance, that select group of patient will not relapse. That is the best. Otherwise, multiple myeloma is not a curable disease. This disease is still going to come. We have to go for second therapy. Life still can be gained, but it's better one therapy, keep the disease under control for a long time. Even in the forest plot, if you see against all the variables, whether it is male, female, age of more than 65, less than 65, any race, ISS staging, high risk or standard risk, everything favored the quadruplet therapy, and that Darzalex VRD should be used upfront. Now this is, it depends as you use Darzalex more and more over a period of time, when you have used in induction, consolidation and maintenance, the depth of remission increases over a period of time. So even if the patient who has missed initially, the daratumumab can be added in the maintenance phase. Now this is the overall minimal residual disease negativity. I said once the patient has undergone transplant and you do the MRD negativity, the more patients were able to go into MRD 75 versus 47%. That is if you go for 10 to the power 5, and in 10 to the power minus 6, it was 65 versus 32 who has received quadruplet versus triplet therapy. So quadruplet therapy favors that you will achieve MRD negativity status that will prolong the progression-free survival and going for operational cure. So a sustained MRD negativity, as I told, if you are able to have a sustained MRD negativity, then you can even stop the maintenance lenalidomide, and that is possible in a patient who has received quadruplet-based therapy, standardized patient. In those, the chances are even better. So I think so. I'm sorry. Yeah. So this is another trial when it was in the Cassiopeia trial that has used intravenous Darzalex, or Perseus trial. The Darzalex remained the center of which has improved the quadruplet therapy as compared to the triplet. Progression-free survival in both, whether you have received IV or subcutaneous Dara, the effect was almost the same. So I'll go in summary. Quadruplet benefits, quadruplet induction followed by transplant followed by consolidation and DR maintenance significantly improved the progression-free survival in the transplant eligible patient, and the depth of response and MRD negativity was much better in quadruplet as compared to triplet. Now coming to the non-transplant dependent, non-transplant eligible newly diagnosed multiple myeloma. Now here the aim is different. Here we have to reduce the symptoms of active myeloma, improve the quality of life, achieve deeper response, balance between maintaining response and tolerability, and enhance the overall survival. So you may not go for very aggressive therapy, you may go for triplets or doublet based on the frailty index score. What our aim is, the patient should be achieving remission, long-term remission, less of side effect. Now how we do it, generally in India we take 65 as a cutoff, more than 65 years of age, and if you can still go for transplant, but more than 70, if the frailty index is high, you go for the transplant eligibility, you go for Dara VMP or VMP based therapy or Lendex or Bordex based therapy. Melphalan, prednisolone, thalidomide still remains one of the standards. So these are different regimens which is available. The whole idea is to reduce the tumor load, increase the survival. Now, this is 2025 guidelines, isatuximab with VRD or DARA VRD in where the frailty index was low, and if the high, then you can go for triplet therapy. And if you add the CD38, the response was even better. Now, what is the result with DARA VRD as compared to doublet, that is RD, in transplant ineligible when they have compared in the Maya trial? Again, addition of daratumab had the better response rate in all the cross group. It's better in standard as compared to the higher risk group. Even in the IS staging, the lesser the ISS1 behaved much better than IS3, but addition of daratumab, you can see what was the progression-free survival at 64.5 months. After the median follow-up of 64.5 months, the median PFS was 61 months with a 45 reduction in disease progression or death in Darzalex arm. So that is the difference at compared to the patient who has received doublet 30 versus 50. So that's the importance. The only hindrance at present is the daratumab is the original brand which is available. It's little cost. If we remove the cost, if the patient who can financially avail till the generics come up, this is the difference. Especially it's the multiple myeloma being the huge load, we should add daratumab in the frontline therapy. Overall survival also it's improves over a period of time, 53 versus 39 in transplant eligible patients. Also in the forest plotting at grains, as I was saying, in the all the age groups in the in gender or even high class or the high risk status, addition of daratumab in the front line in transplant eligible, it all favored the group which has received the daratumab. Now the safety, the rate of treatment discontinuation due to treatment related adverse event was lower in daratumab as compared to the Lendex arm. The grade 3, grade 4 infections were more with DARA because the IgG levels were more, but if you are giving regular immunoglobulins, that rate can be reduced. That's the only side effect with the Darzalex. Otherwise, it's much better as compared to the Lendex. So this is the frontline daratumab Lendex offer durable progression-free survival even in those who have CKD patients, renally impaired patients, and can be easily given the low-dose lenalidomide. The progression-free survival was better, a 45 reduction in the disease or progression or death. So also you should remember in the summary that whole idea in multiple myeloma treatment is in the transplant eligible patient is not to have infections, the quality of life. Even if we are those patients who are not able to afford it, and even giving 2 to 4 months will definitely impact their survival, their quality of life. And if not, doublet therapy should be given to every patient. So the increased incidence of newly diagnosed multiple myeloma, India being number 3rd country in globally for the new cases, management options have improved considerably in last 10 to 15 years, but most cases in multiple myeloma relapses. So the first line therapy remains that what exactly we are in the transplant eligible quadruplet based therapy, in the transplant eligible triplet based therapy is the way to go. With a therapeutic involvement as the newer therapies, bispecifics are coming in the upfront, we are going to see a lot of changes. Maybe the treatment is going to change in the next few coming years when the bispecific comes in the upfront. Currently, it is approved in the first line relapse. With this, I will end my talk. Thank you. Thank you for the patient listening.
Sir, my question is regarding when I passed MBBS around 35 years back. That time, multiple myeloma, we were knowing only one molecule, melphalan. Compared to the era of melphalan to the quadruple therapy, how long the survival has improved?
So melphalan used to be 6 to 9 months survival. Now, at least 70% of the patient, we can easily say any patient coming walking to in the room 5 to 10 years. So that is the change, quadruplet therapy. So from months to years together. So melphalan is still used at the that is the last therapy for every patient. Melphalan, it's not like it has gone. And in transplant, melphalan, injection melphalan is still used as a the standard of care. So transplant has not gone away. Even with the lot of advent, the autologous transplant is the baseline and to be recommended for every patient who is less than 65 years of age.
Sir, next question is regarding autologous bone marrow transplant. can it be used a patient who has already developed a CKD due to multiple myeloma?
Yes, it can be used.
Can be.
Can be done.
Thank you.
Sir, I have a question. In the long-term use, some of the patients when taking the pomalidomide or lenalidomide, the bone marrow suppression is definitely a problem for that. So in that case, should he stop the treatment or should he give the, in case of the Darzalex, whenever we are giving the GCSF. Initially, we are apprehensive about the thing, it can increase the plasma cell also, or the blast cell will be also increased. Is that a real fear, or in that case of the continuation of the pomalidomide or lenalidomide, we should stop few days and then the blood cell will come out, TLC, and then we'll restart that? What should be our approach?
So no clear-cut guidelines or clear-cut. So lenalidomide in India, it's less problematic as what we see in the literature. Low-dose lenalidomide, we have seen patient using 5 years, 10 years, not much of a problem. As compared to the Western data, the lenalidomide in there, the PKPD is different as compared to the Indian subcontinent. So those patients who are having pancytopenia, myelosuppression due to lenalidomide or pomalidomide, you can either dose reduce it or dose by giving the lesser dose and the duration that you can do. Means 21 days to 14 days or 10 days according to how the patient is tolerating. Intermittent use of GSF should not be a problem. That also can be done if the patient is infective.
Sir, one thing is also that the subcutaneous bortezomib is nowadays standard of care for the neuropathy control. But nowhere in the vial it is being written. Some of the overconscious patient came to us, why you are not proposing to the pharma company that IM or IV subcutaneous can be given?
So the trial was done for the Velcade only, and the Velcade was available both as which is the original brand of Johnson & Johnson. Velcade still available, and the trial was done with Velcade. And what the R&D has not been done for the subcutaneous version, so they never got the approval. So this question arises on and off when the patient is overzealous when they say IV or subcutaneous. We have to explain to them it is the same thing which has been done, and they are apprehensive, use IV, otherwise using subcutaneous should not be a problem. Only they should be educated in the same thing.
Sir, one more. The thing is that most of the patients with the elderly having the diabetes, and we have to give the dexamethasone. So in that case, how will D, one? And second is that along with ecosprin, can we change to the other blood thinners?
Please repeat the question.
Dexamethasone. One first question is that some of the patient having the diabetes, we have to give the dexa definitely. In that case, how the dose adjustment will be hampering the treatment?
So dexamethasone, what we have said initially when it was started, it was 40 milligram weekly. It is very toxic dose. They themselves have reduced. Indian patients do not tolerate 40. So not more than 20 milligram weekly. Now those who are diabetic, you can easily reduce to 8 milligram. Okay, the other is blood thinners.
Yes, sir.
So blood thinner used for any patient more than 65 years of age. On any patient who is on lenalidomide, the blood thinner should be used. Ecosprin you should be adding. Even if the lenalidomide is not there or pomalidomide is not there, any patient more than 65 years of age or diabetic or cardiac, blood thinner usage is not a problem.
Sir, one particular case was that the patient was in Eliquis, and after that the patient was diagnosed on this. He was having a history of the CABG. So that's why the doctor or cardiologist given Eliquis. So in that case, should we re-add ecosprin or we continue the Eliquis on?
Just continue Eliquis. Do not add ecosprin.
Thank you, sir. Thank you.
Thank you, sir, for the excellent talk, and thanks to all the chairpersons for chairing the session.
Thank you.
Now we request Dr. Satish to announce the poster presentation winners.
So now moving to last section, we had also poster presentation. So we received total of 26 posters and oral presentation. And we had people from RIMS, from different hospitals who presented posters. The first prize is to Dr. Nidhi Kashyap. She is not there. No, if any friend of उनके साथ कोई है तो आके ले सकते हो. Okay, fine. Dr. Ambuj Mishra. Third prize is to Dr. Preeti. Yeah. Also, there is a jointly third prize that is to Dr. Sambreen. That is, she's from our team. We presented around 6 posters from Manipal hospitals. Dr. Kallan, please. He is a Also, we have Dr. Rohit Pandey, who is from whose felicitation was left. I think it was. So I will, on the behalf of the organizing committee, Dr. Satish, I will thank everyone for making it a huge success. And we can hear this clap on a Sunday afternoon. And I was talking to most of my friends to find, it is very difficult to find listeners. We can find speakers, panelists, but then it was an effort from the team and everyone, then we can find audience in such a big number. Thank you, everyone. We will come again in this time with Ranchi Cancer Summit 3. Thank you.